Good morning, everyone. Today's OT2 case is a 18-year-old male who has presented with history of neck pain for last 2 years and numbness and tingling in all 4 limbs for last 2 years and weakness in right side upper limb and lower limb for last 3 months. There's also associated history of slip and fall over back 6 years back, and there is no history of any sensory loss or no history of any bladder or bowel complaints. On examination, in the sensory system, there is no sensory loss or any dermatome. In motor system, the bulk is reduced in right thenar and hypothenar muscles of the hand as compared to left. There is grade 2 spasticity in all 4 limbs. Power is 4/5 in right side upper limb and lower limb, and 5/5 in left side upper limb and lower limb. There are exaggerated deep tendon reflexes across all joints. Plantars are upgoing, Hoffman's positive bilaterally, and inverse supinator also positive. So the imaging, the dynamic X-ray shows atlantoaxial dislocation, which is reducible in extension. So this is the pre-op CT. This is sagittal CT with the CT angio, CT CVJ with CT angio, which shows relation of the vertebrals. CT was also done in extension, which shows reduction of AD. This is the axial cut. This is the coronal CT CVJ with CT angio. And the VRT 3D recon showing relation of the joints with the vertebrals. Preoperative MRI done shows kinking at the level of cervicomedullary junction with a ADI of 5.9 mm. So this is the pre-op MRI showing kinking at the cervicomedullary junction. So this is a case of mobile AED, and this is planned for anterior C1 C2 transarticular fixation. I would like to invite Professor Sushil Patkar sir for further discussion.
Good morning. So atlantoaxial dislocation, the whole thing, treatment depends upon the reducibility. This is, you have seen in extension, it is reducing. So once it is reduced, how you fix, whether you select to fix from behind or from the front, is your kind of choice, what you want to do. I am proposing a concept that it is easier to be done from the front because this operation is done in supine position with head in extension, that is the position in which it is reducing, unlike doing it in prone position. Plus, can you get a 3D reconstruction images? Like I said yesterday, the best fixation to fix a joint is to, where rotation is the predominant movement, is to pass the screw across. So when you see this, get the AP and stop it over there. Stop it at the AP. So when we look at this, when we see this structure, if we are able to pass one screw across and one screw across this, that will have impaled and stopped the rotation. There is enough bone actually to pass even 2 screws. But the first I will pass one screw from here across and one screw from here across in the extended position. And I think that should be more than enough by after preparing the joints and putting bone grafts in the joint. Can you show me that one image where I did the measurements? Is that image there? So the preoperative planning consists of, first is where the vertebral artery is going. See, in both these cases, the vertebral artery is going laterally. There is no impedance to my, it is nowhere in my way of where I'm going to pass the screws. The second thing is that there is a lot of strong bone available for me over here. Always the facets, the stress lines of the vertebra are just under the facet joint. So you got very strong bone and you got this notch from which you can pass the screw across. Yesterday, Professor Vasilievich asked to set the question about difficulty in passing the ipsilateral screw. So once if I have any difficulty, I will drill a little bit of bone over here so that I can angle my drill properly. But it is required very rarely. You must always have a second option. You must remember that the screw must start at least 5 to 6 millimeters below and medially. There must be adequate amount of bone. Sometimes people make the mistake of starting the screw very close to the joint and the bone on top fractures. And that can end up in a difficult situation. So you must plan your entry point 5 millimeters. And the more medial you are, the more unlikely that you will injure the vertebral artery. So take it 5 millimeters below and medial and then pass it across. On the AP, the screw should be directed towards the upper outer edge of the lateral mass, and the lateral it should be directed towards the posterior upper end of the lateral mass. So these are the kind of 2 important landmarks where you should pass, take the direction of the screw. The single most preoperative important test is to do a lateral X-ray without any parallax to the mandibles, and the mandibles must be above the C2-3 disc or up in the upper part of the C. If it is going anywhere below that, then it is very difficult to do this case from the, of course, with nowadays I use the endoscope and I'll dissect and even do it under endoscope, but then that is it makes the thing more and more complex. In 90% of the times, you will find that the angle of the mandible comes up to the C2-3 disc or above. In this case, it is coming slightly above the C2-3 disc. They have not brought the image. I'll show it to you from the OT. So I feel that this will be relatively a very easy case to do. If there are any questions, I am ready to take them.
Professor Patkar, so there is a tilt. Are you going to correct the tilt by using a slightly different height of a cage on one side?
I'm not going to put any cages. See, in this case, you'll find, can you go to the sagittal image in extension? This is an old fracture odontoid where probably this is the distal end. As we have to remember, in all fracture odontoids, never does the distal fragment leave its alignment with the anterior arch of the atlas. The transverse ligament is invariably intact. What gets disrupted is the vertical part of the cruciate ligament, and that is what decides the instability. Now, in this case, you'll find, stop it over, stop it over, stop it over. So you'll find that this bone has been, the cortical margin is reformed, a very old fracture. The idea is only to get in extension, relieve the compression, and fix it in that position.
Now I'm asking about the tilt.
Tilt off?
The C1, C2.
Yeah, the moment you open the joints and you hold the, I'll be having crutch field tractions. So when I hold the crutch field traction, that will help in correcting the lateral tilt.
Yeah, sir.
While choosing any case for anterior approach, what are the special aspects in terms of radiology while choosing such case?
All that I said. One is that the angle of the mandible should be above. There should be no vertebral artery coming medially. There should be a lot of bone under the entry point, and these are three main requirements.
And while placing the patient on OT table, what should be the optimum degree of extension at neck? How to find that this is the best position for in extension?
You see, do the CM and see that you have got the reduced position of the dislocation. You confirm that you are getting the reduction on the extension X-ray, and that in that position you are going to fix the patient.
Thank you, sir.
Dr. Patkar, last time also we saw this excellent way you exposed and did the surgery. I just want to know, when we expose the joints bilaterally and we don't have your plates available, can we put something else?
You can put anything.
Can we put a mini plate?
Yes, you can put a mini plate. The plate should be more than 3. See, the requirements now biomechanics over the years, any plate which is between 2.7 to 3 mm in thickness and which accommodates a 3.5 to 4 mm screw is good enough for the subaxial spine, and same thing is good enough for the atlantoaxial dislocation. But to fix dislocation, I prefer a transarticular screw. The plate is a salvage when the screw cannot be done.
Okay. So standard transarticular screws can we put in this?
More than sufficient. 3.5 to 4 mm, even 4.5 mm.
And if we want to put a plate, we can use any mini plate and just
Any mini plate. Pass one screw in the lateral mass and one in the body or subfascial region of the C2.
Yeah, sir. At times, despite the angle of mandible being at the optimum level, the submandibular gland is quite bulky. So how do you manage that? Number two, do you pre-operatively plan or preoperative? The problem is at times getting that angle in which the screw goes, because you may have to have a more inferior angulation to get into the joint. At times that becomes quite, there is very small bit of bone in front of the screw. So can you on the preoperative MRI anticipate this problem? Preoperative, sorry, CT. 3D
CT, where that 3D CT.
Yeah.
Always on the pre-op CT, you can, on the 3D reconstruction.
So
you-
even in this case,
Yeah,
I
you can
believe that ledge may be quite small to the screw, the bone in front of the screw in the C2 will be very small.
I don't think there will be a problem, especially if there is a ledge. If sometimes this is flat, and that is the time there is a problem.
Yes, yes, yes.
In children, this ledge is not formed many times. Then there is a problem. So then you have to use a plate where you keep the plate across, put one screw over here and one screw over here. And then this new plate which I talk about nowadays is where I put one screw here, one screw here, one screw in the center. So that there were, so obviously when you do this, all your options should be available on the table. You can't open and then say that this implant is not there. So all you have to have a plan B, plan C ready in the operation theater. And of course you should also be able to do good posterior fixation. If there is any problem, you must be good enough to turn the patient into a posterior fixation also. But the chances that you require that is very, very less. But you cannot go and say that I do only anterior surgery, and if now it cannot be done, thank you very much.
Yeah, so submandibular, how do you manage submandibular?
Yeah, submandibular is rarely in the way. Plus you can dissect it, take a stitch and pull it up. Yeah, our entry into the prevertebral space is much below the submandibular gland. It is below the digastric tendon. The submandibular gland is always above the digastric tendon. So submandibular gland, rarely, I have never encountered in so many cases that submandibular gland created trouble for me. I don't know whether Professor Visochi can add. Do you think submandibular gland has created trouble for you any time?
At the very beginning of my experience in submandibular approach, I isolated the submandibular gland, I shifted it up, and someone removed it, but I was used just to shift it up. But with this new modified 3 steps technique that I showed you yesterday and today I will repeat to you, I don't do that. I don't want look for submandibular.
Correct.
Exactly as a follower approach. When we perform anterior cervical decompression infusion procedures, in the book you can see that you have to isolate carotid artery, vagus nerve, jugular nerve. You don't need that. just to identify your target. But the risk of this minimally invasive approach is to have a very short mobility and a very small surgical domain. So, my question is, since we have two ways to manage this anterior approach, submandibular and lowered high subaxial approach, both has the possibility to control your target, but probably the subaxial lowered approach has a more comfortable angulation to engage the surgical line. What kind of approach you choose in this case? And second question, how long is the screw? And third question, which is the X-rays target? Because I think that I suppose that you operate under X-rays guidance, not 3D neuronavigation. Which is the radiological X-ray standard target to be sure that you reached the final part of your track with your screw?
So question number one, the kind of Clowards approach is good when you are doing an odontoid screw. It is not a good approach for passing the lateral mass screws because the trajectory and the distance becomes very big to reach from the subaxial spine to this point. Whereas when you go from the submandibular region, you have direct access to that area. This is answer to question number one. The question number two was the radiological landmarks. What was question number two? There's no neuronavigation so far has got a tracker which can be put on the anterior spine. Now EasyNav, there's a company, they're making for me a tracker which can be fixed with pins to the C3 body. But I prefer not to dissect from above downwards because once you start dissecting from above downwards, there's a larger chance of injury to the superior laryngeal nerve. If you go directly to the body here and dissect upwards, you are not going to damage the superior laryngeal nerve. But if you work from above, because the superior laryngeal nerve comes from here up above. So if you dissect below from top, you are going to end up in trouble. Try to remain, at the C2-3 disc and try to put the tracker over here, or then you can do the navigation. Otherwise, the X-ray is good enough. Over a period of time, I don't even use the X-ray because once I see the screw going across the joint, and if it has gone more than a centimeter into the lateral mass of C1, that is more than sufficient. So, of course, but the C-arm you can always use, and you can do the lateral C-arm and the AP C-arm, the screw should be directed in this direction, and in the lateral it should be directed towards the posterior end of the lateral mass. So, but when you are passing the screw, when you see the screw going across the joint, immediately any movement between the C1, C2 stops. And then if you go on even 10 millimeters or 12 millimeters into the lateral mass, that is more than sufficient. In fact, when you do posterior transarticular screws, the engagement in the lateral mass is much less because of the trajectory. So anteriorly, you get a bigger trajectory into the lateral mass of C1. You have to be only careful about seeing that you start adequately down and don't start very close to the joint. Many times it has happened in the beginning, I should start over and then fracture as I'm tightening, and then I'm in trouble. You can also augment it by putting one more screw from here into the vertical screw into the lateral mass of C1. Once you're exposed, you have to remember that the joint is about a centimeter to centimeter and a half above the disc space. So go about a centimeter. I have already seen yesterday on the CT scan that the joints are about 1.5 centimeter above the C2-3 disc. So once I dissect up, I will take and cut the longus colli muscle on both sides. Once I have cut the longus colli, there is nothing else but the joint underneath. I think I've answered. There's one question I missed. There are three questions or two questions. Length of screw. Length of screw is entirely based on the CT scan evaluation preoperatively. So that we have measured yesterday the height of the atlas, what is the height of the atlas, how much when you take the trajectory laterally, how much it is, and the quality of bone also. Sometimes there is some cystic degeneration in the lateral mass.
Yes, and due to the uncomfortable angulation of ipsilateral mass joint, someone use malleolar screws, the shorter one, ipsilaterally, and the longer one contralateral. Do you do that?
No, I don't. I'm telling you that if there is any difficulty in passing the ipsilateral screw, what you have to do is hold the drill and maybe drill about, a few millimeters of the cortex over here. Rarely I need to do that. Most of the time when I see a CT scan like this, it is doable to pass the screws. But if at all is any difficulty, I will take a diamond burr or a cutting burr and make a little trough over here. The difficulty is because of this hump, which is variable. Sometimes it is very big, sometimes it is flat. But in this case, if there's any trouble, I might have to drill a little bit here so that it doesn't obstruct my drill. This is another important point, that you must have an angle drill. You must always have an angle drill, which you turn reverse, so that you can hold the drill. There is angle drill which you turn upside down and hold it in your hand, and the drill bit should be at least 3.5 mm in length, in thickness, and 30 to 35 mm in length. So you must have a good drill bit. I always have 2 or 3 drill systems on the table. Medtronics unfortunately comes only with one drill bit. It is a very good drill, but it is very, very small. It is only 8 mm. So the other drill which I have on table is either NSK or Ben Air, which has got a longer drill bit. AP, I don't need to do open mouth because I'm not trying to see the odontoid. The lateral masses are well, unless and until there's a difficulty in seeing the lateral masses. If you tilt the C-arm image, you will see where the lateral masses are. The open mouth is important when you're passing the odontoid screw because you have to see the odontoid.
And I believe you use fully threaded screw and not lax screw.
Yes, I have got the special fully threaded screws which have been made by Jeon.
Yeah.
I am comfortable with those. And they have a good hold both in the lateral mass also and the facet also.
Thank you, sir.
Who is next?
18-year-old male who has presented with a history of neck pain for last 2 years and numbness and tingling in all 4 limbs for last 2 years and weakness in right side upper limb and lower limb for last 3 months. There is also an associated history of slip and fall over back 6 years back, and there is no history of any sensory loss or no history of any bladder or bowel complaints. On examination, in the sensory system, there is no sensory loss or any dermatome. In motor system, the bulk is reduced in right inner and hypothenar muscles of the hand as compared to left. There is grade 2 spasticity in all 4 limbs. Power is 4/5 in right side upper limb and lower limb, and 5/5 in left side upper limb and lower limb. There are exaggerated deep tendon reflexes across all joints. Plantars are upgoing. Hoffman's positive bilaterally, and inverse supinator also positive. So the imaging, the dynamic X-ray shows the atlantoaxial dislocation, which is reducible in extension. So this is the pre-op CT. This is parietal CT with the CT angio, CT severe with CT angio, which shows relation of the vertebrals. Shows atlantoaxial dislocation, which is reducible in extension. So this is the pre-op CT. This is parietal CT with the CT angio, CT severe with CT angio, which shows relation of the vertebrals. CT was also done in extension, which shows reduction of AD. CT was also done in extension, which shows reduction of AD. This is the axial cut. This is the axial cut. This is the coronal CT CV with CT angio. This is the coronal CT CVJ with CT angio. And the VRT 3D recon showing relation of the joints with the vertebrals. And the VRT 3D recon showing relation of the joints with the vertebrals. Preoperative MRI done shows kinking at the level of cervicomedullary junction with a ADI of 5.9 mm. This is the pre-op MRI showing kinking at the cervicomedullary junction. So this is a case of mobile AED, and this is planned for anterior C1 C2 transarticular fixation. I would like to invite Professor Sushil Patkar sir for further discussion. This is the pre-op MRI showing kinking at the cervicomedullary junction. So this is a case of mobile AED, and this is planned
Good morning.
for anterior
So,
C1 C2 transarticular.
Plan to axial dislocation, the whole thing, treatment depends upon the reducibility. This is, you have seen in extension, it is reducing. So once it is reduced, how you fix, whether you select to fix from behind or from the front, is your kind of choice of what you want to do. I am proposing a concept that it is easier to be done from the front because this operation is done in supine position with head in extension. That is the position in which it is reducing, unlike doing it in prone position. Plus, can you get a 3D reconstruction images? Like I said yesterday, the best fixation to fix a joint is to where rotation is the predominant movement, is to pass the screw across. So when you see this, get the AP and stop it over there. Stop it at the AP. Plus, can you get a 3D reconstruction image? So when we look at this, like I said yesterday, the best fixation to when we see this structure, if we are able to pass one screw across or one screw across this, that will have impaled and stop the rotation. There is enough bone actually to pass even two screws. But the first I will pass one screw from here across and one screw from here across in the extended position. And I think that should be more than enough by after preparing the joints and putting bone grafts in the joint. Can you show me that one image where I did the measurements? Is that image there? Actually to pass even two screws. So the preoperative planning consists of first is where the vertebral artery is going. See, in both these cases, the vertebral artery is going laterally. There is no impedance to my part. It is nowhere in my way of where I'm going to pass the screws. The second thing is that there is a lot of strong bone available for me over here. Even the facets, the stress lines of the vertebra are just under the facet joint. So you got very strong bone and you got this notch from which you can pass the screw across. Yesterday, Professor Vasilievich asked to set the question about difficulty in passing the ipsilateral screw. So once if I have any difficulty, I will drill a little bit of bone over here so that I can angle my drill properly. But it is required very rarely. You must always have a second option. You must remember that the screw must start at least 5 to 6 millimeters below and medially. There must be adequate amount of bone. Sometimes people make the mistake of starting the screw very close to the joint and the bone on top fractures. And that can end up in a difficult situation. So you must plan your entry point 5 millimeters, and the more medial you are, the more unlikely that you will injure the vertebral artery. So take it 5 millimeters below and medial and then pass it across. On the AP, the screw should be directed towards the upper outer edge of the lateral mass. On the lateral, it should be directed towards the posterior upper end of the lateral mass. So these are the kind of two important landmarks where you should pass, take the direction of the screw. The single most preoperative important test is to do a lateral X-ray without any parallax to the mandible, and the mandible must be above the C2-3 disc or up in the upper part of the C. If it is going anywhere below that, then it is very difficult to do this case from the, of course, with nowadays I use the endoscope and I'll dissect and even do it under endoscope, but then that is it makes the thing more and more complex. Because in 90% of the time, you will find that the angle of the mandible comes up to the C2-3 disc or above. In this case, it is coming slightly above the C2-3 disc. They have not got the image I'll show to you from the OT. So I feel that this will be relatively a very easy case to do. If there are any questions, I am ready to take them. It makes the thing more and more complex. Because in 90% of the time, you will find that the angle of the mandible comes up to the C2-3 disc. In this case, it is coming
So there is a
above the C2-3 disc.
tilt.
They have not got the
Are you
image I'll
going
show
to
you
correct the
from
tilt by using a slightly different height of a cage on one side?
I'm not going to put any cages. See, in this case, you will find, can you go to the sagittal image in extension? This is an old fracture odontoid, where probably this is the distal end, as you have to remember, in all fracture odontoids, never does the distal fragment leave its alignment with the anterior arch of the atlas. The transverse ligament is invariably intact. What gets disrupted is the vertical part of the cruciate ligament, and that is what decides the instability. Now, in this case, stop it over. So you will find that this bone has been, the cortical margin reformed, a very old fracture. The idea is only to get an extension, relieve the compression and fix it in that position.
Now I'm asking about the tilt.
Tilt off?
The C1, C2 on
Yeah, the moment you open the joints and you hold the, having crutch field tractions. So when I hold the crutch field traction, that will help in correcting the lateral tilt. The idea is only to get an extension.
Yeah, sir.
While choosing any case for anterior approach, what are the special aspects in terms of radiology while choosing such case?
All that is said. One is that the angle of the mandible should be above, there should be no vertebral artery coming medially, there should be a lot of bone under the entry point, and these are three main requirements.
While placing the patient on OT table, what should be the optimum degree of extension at neck? How to find that this is the best position for extension?
You see, do the CM and see that you have got the reduced position of the dislocation. You confirm that you are getting the reduction on the extension X-ray, and that in that position you are going to fix the patient.
Thank you.
Dr. Patkar, last time also we saw this excellent way you exposed and did the surgery. I just want to know, when we expose the joints bilaterally and we don't have your plates available, can we put something else?
You can put anything.
Can we put a mini plate?
Yes, you can put a mini plate. The plate should be more than 3. See, the requirements now biometric over the years, any plate which is between 2.7 to 3 mm in thickness and which accommodates a 3.5 to 4 mm screw is good enough for the subaxial spine, and same thing is good enough for the atlantoaxial dislocation. But to fix dislocation, I prefer a transarticular screw. The plate is a salvage when the screw cannot be done.
So standard transarticular screws can we put in this?
More than sufficient. 3.5 to 4 mm, even 4.5 mm.
And if we want to put a plate, we can use any mini plate and just...
Any mini plate. Pass one screw in the lateral mass and one in the body or subfascial region of the C2.
Yeah, so at times, despite the angle of mandible being at the optimum level, the submandibular gland is quite bulky. So how do you manage that? Number 2, do you preoperatively plan or preoperative? The problem is at times getting that angle in which the screw goes, because you may have to have a more inferior angulation to get into the joint. At times that becomes quite, there is very small bit of bone in front of the screw. So can you on the preoperative MRI anticipate this problem? Preoperative, sorry, CT, 3D
CT, that 3D CT. Always on the pre-op CT you can, on the 3D reconstruction.
So, and even in this case, I believe that ledge may be quite small to the screw, the bone in front of the screw in the C2 will be very small.
I don't think there will be a problem, especially if there is a ledge. Sometimes this is flat, and that is the time there is a problem. In children, this ledge is not formed many times. Then there is a problem. So then you have to use a plate where you keep the plate across, put one screw over here and one screw over here. And then this new plate which I talk about nowadays is where I put one screw here, one screw here, one screw in the center. So that's very well. So obviously when you do this, all your options should be available on the table. You can't open and then say that this implant is not there. So you have to have a plan B, plan C ready in the operation theatre. Of course, you should also be able to do good posterior fixation. If there is any problem, you must be good enough to turn the patient into a posterior fixation also. But the chances that you require that is very, very less. But you cannot go and say that I do only anterior surgery and if now it cannot be done, thank you very much.
Yeah, so submandibular, how do you manage
Yeah, submandibular is rarely in the way. Plus you can dissect it, take a stitch and pull it up. Yeah. Our entry into the prevertebral space is much below the submandibular gland. It is below the digastric tendon. The submandibular gland is always above the digastric tendon. So submandibular gland rarely, I have never encountered in so many cases that submandibular gland created trouble for me. I don't know whether Professor Visochi can add. Do you think submandibular gland has created trouble for you any time? Entry into the prevertebral space is much below the submandibular gland. It is below the digastric tendon.
At the very beginning of my experience in submandibular approach, I isolated submandibular gland, I shifted up, and someone removed it, but I was used just to shift it up. But with this new modified three steps technique that I showed you yesterday and today I repeat to you, I don't do that. I don't want to look for submandibular.
Correct.
Exactly as a closed approach. When we perform anterior cervical decompression and fusion procedures, in the book you can see that you have to isolate carotid artery, vagus nerve, jugular nerve. You don't need it. Just to identify your target. But the risk of this minimally invasive approach is to have a very short mobility and a very small surgical domain. So, my question is, since we have two ways to manage this anterior approach, submandibular and closer high subaxial approach, both has the possibility to control your target, but probably the subaxial closer approach has a more comfortable angulation to engage the surgical line. What kind of approach you choose in this case? And second question, how long is the screw? And third question, which is the X-rays target? Because I think that I suppose that you operate under X-rays guidance, not 3D neuronavigation. Which is the radiological X-ray standard target to be sure that you reached the final part of your track with your screw?
So question number one, the kind of clowards approach is good when you are doing an odontoid screw. It is not a good approach for passing the lateral mass screws because the trajectory and the distance becomes very big to reach from the subaxial spine to this point. Whereas when you go from the submandibular region, you have direct access to that area. This is the answer to question number one. The question number two was the radiological landmarks. What was question number two? There's no neuronavigation so far has got a tracker which can be put on the anterior spine. Now EasyNav is a company, they are making for me a tracker which can be fixed with pins to the C3 body. But I prefer not to dissect from above downwards because once you start dissecting from above downwards, there's a larger chance of injury to the superior laryngeal nerve. If you go directly to the body here and dissect upwards, you are not going to damage the superior laryngeal nerve. But if you work from above, because the superior laryngeal nerve comes from here, right. So if you dissect below from top, you are going to end up in trouble. Try to remain, at the C2-3 disc and try to put the tracker over here, and then you can do the navigation. Otherwise, the X-ray is good enough. Over a period of time, I don't even use the X-ray because once I see the screw going across the joint, and if it has gone more than a centimeter into the lateral mass of C1, that is more than sufficient. So, of course, but the C-arm you can always use, and you can do the lateral C-arm and the AP C-arm. The screw should be directed in this direction, and in the lateral it should be directed towards the posterior end of the lateral mass. But when you are passing the screw, when you see the screw going across the joint, immediately any movement between the C1 C2 stops. And then if you go on even 10 millimeters or 12 millimeters into the lateral mass, that is more than sufficient. In fact, when you do posterior transarticular screws, the engagement in the lateral mass is much less because of the trajectory. So anteriorly, you get a bigger trajectory into the lateral mass of C1. You have to be only careful about seeing that you start adequately down and don't start very close to the joint. Many times it has happened in the beginning, I should start over and then fracture as I'm tightening, and then I'm in trouble. You can also augment it by putting one more screw from here into the vertical screw into the lateral mass of C1. Once you expose, you have to remember that the joint is about a centimeter to centimeter and a half above the disc space. So go about a centimeter. I have already seen yesterday on the CT scan that the joints are about 1.5 centimeter above the C2-3 disc. So once I dissect up, I will take and cut the longest scoli muscle on both sides. Once I have cut the longest scoli, there is nothing else but the joint underneath. I think I've answered. There's one question I missed. There are 3 questions or 2 questions. Length of screw. Length of screw is entirely based on the CT scan evaluation pre-operatively. So that we have measured yesterday the height of the atlas, what is the height of the atlas, how much when you take the trajectory laterally, how much it is, and the quality of bone also. Sometimes there's some cystic degeneration in the lateral mass. There are 3 questions or 2 questions.
Yes, and due to the uncomfortable angulation of ipsilateral mass joint, someone used malleolar screws, shorter one, ipsilaterally, and longer one, contralateral. Do you do that?
No, I don't. I'm telling you that if there is any difficulty in passing the ipsilateral screw, what you do is hold the drill and maybe drill about a few millimeters of the cortex over here. Rarely I need to do that. Most of the time when I see a CT scan like this, it is doable to pass the screws. But if at all there is any difficulty, I will take a diamond bore or a cutting bore and make a little trough over here. The difficulty is because of this hub, which is variable. Sometimes it is very big, sometimes it is flat. But in this case, if there is any trouble, I might have to drill a little bit here so that it doesn't obstruct my drill. This is another important point, that you must have an angle drill. You must always have an angle drill, which you turn reverse, so that you can hold the drill. There is angle drill which you turn upside down and hold it in your hand, and the drill bit should be at least 3.5 mm in length, in thickness, and 30 to 35 mm in length. So you must have a good drill bit. I always have 2 or 3 drill systems on the table. Mechatronics unfortunately comes only with one drill bit. It is a very good drill, but it is very, very small. It is only 8 mm. So the other drill which I have on table is either NSK or Ben Air, which has got a longer drill bit. Thickness and 30 to 35 mm in length. So you must have a good AP. I don't need to do open mouth because I'm not trying to see the odentoid. The lateral masses are well, unless and until there is a difficulty in seeing the lateral masses. If you tilt the CN image, you will see where the lateral masses are. The open mouth is important when you are passing the odentoid screw because you have to see the odentoid.
And I believe you use fully threaded screw and not black screw.
Yes, I have got the special fully threaded screws which have been made by J-On.
Yeah.
I am comfortable with those. And they have a good hole both in the lateral mass also and the facet also. The open mouth is important when you are passing the odentoid screw because you have to see the odentoid.
And I believe you use fully threaded.
Shoulder back, can you please focus here? There's a brochure below the shoulder back, and the head is in complete extension. We have put for traction we have put this pins and strap the head so that it doesn't move during the surgery. So it is completely fixed in extension, and this is based on the X-ray. Can you please show that? The head is in complete extension. So you can see the X-ray, which is we want the C1C2 in the reduced position where we can fix it, and that is perfectly reduced now. It is a camera zoom in, please.
Can you adjust the angle? Yeah. Okay. Yeah, looks good.
Can you please show that? Okay.
Yeah. No, it's okay. It's okay. You can see.
So the C1C2 is completely reduced here, The other thing we want is that the alignment of the occipiting line. So more or less it's okay. Somehow the C1 arch is not exactly perfectly aligned, but so intraoperatively we will be, while putting the drill in CT, we will try to manipulate with our assistant Dr. Ishan will be there to move the head and then keep his alignment before we drill into the CT and then go to C1. So that is our plan. We are just beginning to do our incisions. Dr. Patkar already had marked it, but because Ishan was painting, it is gone. So it is basically just below the mandible, one finger breadth below the mandible. And it starts from the anterior border of the sternocleidomastoid. So this is roughly the sternomastoid here. And one finger breadth below. So it starts from here. And the incision will curve slightly towards the midline. This is basically to expose the digastric tendon, and we actually detach it from the hyoid bone so that we get an axis above. We'll have to retract it below. That's the reason this upcurving is there. And this is our incision for the exposure.
Can you show the incision properly? We could not see it.
इधर दिखाओ मैं नहीं दिख रहा उनको. Now can you see it?
Yeah, perfect.
So this is the incision starting from the anterior border of the sternomastoid and curving just in the midline.
Perfect. Can you show the incision properly? So, not see it. You want to see the MRI? Can you glide the take us to the MRI once?
हाँ MRI को दिखाना.
Yeah, perfect.
Zoom.
No.
No, that is CT or X-ray.
So there is a question. Your incision does it cross the midline or only one?
So just at the midline. It doesn't cross it. Just towards the midline, it just curves upwards.
Perfect.
And we are also taking the iliac graft.
Okay.
For taking the bone graft.
Show us the MRI once.
MRI, please.
So there is a question. Your incision does it cross the midline or?
Is it visible? Just at the midline. Yeah. It doesn't cross it. Just towards the midline. The lighting conditions are not very great. And we are also taking the iliac graft. ये थोड़ा ऊपर हो सकता है स्क्रीन के?
Okay.
For taking the bone graft.
Show us the MRI once.
The MRI is visible?
Zoom in.
Zoom कर दो.
Zoom on T2.
तो कैमरा थोड़ा पास में लाओ.
Now what you want?
और फिर
You have to ask you. Okay, he wanted to see a cord pinching. Anything else? You are happy now? Yeah.
Is it visible?
Yeah, it's visible.
Yeah.
Thank you. Can you take to OT4?
Zoom in. Zoom कर दो. तो कैमरा थोड़ा पास में लाओ.
Now what you want?
और फिर
You have to ask you. Okay, he wanted to see a cord pinching. Anything else? You are happy now? Yeah.
Is it visible?
Yeah, it's visible.
Yeah.
Thank you. Can you take to OT4?
एक मिनट रुको. Can I help you? Can I help you?
Yes. Hello.
Can you did that ether over?
OT4, please.
Local. Somebody has to detach this.
OT4.
Help you? Where shall I help? Live?
Yeah, Professor Deshpande is aware with you.
Live? Okay. And you have to put over that.
Professor Raja Kumar, where with you?
Hello? Can you hear me?
Yeah, perfectly.
So, good morning once again. We are trying to organize the OT. We have just got things to a shape. And I'll start with the marking, step-by-step approach. So people who know already might find it boring, but people who are right into the minimal access initially, they can watch what I do and see if it benefits them. It's a very straightforward step-by-step approach, like I showed during the cadaver section. And the same process, if it is followed on a regular basis, Dr. Patkar sir.
becomes a way of habit. So
Hello.
give me 5 minutes and I think I'll be with you guys.
Yeah, perfect. We'll come back to in 5 minutes.
Hello.
Can you take to
Hello.
Just I wanted to know, the head has to be straight completely in neutral position, or it is slightly turned while we are taking the incision?
We have turned a bit because our exposure is from this side. This is just for the exposure part. But when we are planning to put a screw, then we will have it exactly neutral and then in alignment. Perfect lateral and complete extension.
Is there any indication for taking from the left side also, or most of the time from right side?
This is just for the exposure part. I think you have to wait for Dr. Patkar to be here to answer that question. So I will get that answer.
Yes, please. Sure.
Perfect lateral and complete extension.
So is there any indication for taking from the left side also, or most of the time from right side?
Here, left hand island. So I will get that answer.
So while Dr. Patkar is coming, can we go?
So when by the time Dr. Patkar comes, I will get back online.
Yeah, sure.
Right?
Sure.
Okay. Thank you.
Let's go to
OT1.
OT1.
Yes, OT1 you are connected, sir.
Left hand island.
So while Dr. Patkar is coming, can we go?
So when by the time Dr. Patkar comes, I will get back online.
Yeah, sure.
Right?
Sure.
Okay. Thank you.
Let's go to
OT1.
OT1.
Yes, OT1 you are connected, sir.
Yeah. Yes.
Yes, Professor.
I'm here.
Kolesov, yes, you are connected.
Look here, please.
So I want to know what are you doing?
I'm doing posterior approach, and I'm going to check level on that part of the spine. I'm waiting for all, and after this we're doing C-arm control.
Correct.
कंपनी वाला कहाँ है?
So as you see, all the cases are just getting ready. They are initial stages. So if anyone has any question or some comments or anything, they can just let us know. We can communicate with.
Caller mic to Professor Patkar.
Yes, sir, OT2 you are connected.
But he is not available right now.
Caller mic to Professor Patkar.
Enjoying his coffee.
Just OT2.
Yes, sir, OT2 you are connected.
Yeah,
sir.
connect caller mic to Professor Patkar.
Is there anything placed under the neck, below the neck, or it's free? Is there anything placed under the neck, below the neck, or it's free?
We shift to OT4.
सर चुनने का नहीं
ठीक है तो डॉक्टर पाटकर को तो लगा
सर कितने का ना
माइक तो लगा सकते हो. So I want to tell everybody that the streaming is going on. Audio is only one OT continuously. That is Dr. Art's OT. So at least his audio can be heard continuously if you are interested. Rest of the OTs will be without audio unless.
If you can wait for
main OT
couple of minutes.
So in OT2, Ramesh, good morning, sir.
Yeah, hello.
I have a basic doubt regarding the GW traction what we have put now, sir. I think it's there in the flexion position. It's behind the tragus line. You could have put in the anterior to the tragus line. That could have been given a good extension. So in OT2,
Okay, is that so?
Ramesh, good morning, sir.
Yeah, hello.
I have a basic doubt.
Yeah.
Good question.
Yeah, you're right, but
I think
it's I think just for I will let Dr. Patkar come. I think he will answer better.
Question is very relevant.
It's very relevant, yeah.
Traction is put in the flexion behind the tragus lines when we have facetal dislocation, because that is the best way to reduce any kind of dislocation. And usually when we just want extension, it should be put anterior to the tragus line. So if we can just show where the traction Traction is put on the flexion behind the tragus line when we have facetal dislocation. That is the best way to reduce any kind of dislocation. And usually when we just want to to the tragus line.
Hello, good morning, good afternoon.
Good morning, Dr. Patkar.
Yes, sir. Any questions?
Many. So, starting from the position
Yeah.
to the incision and to the reduction on X-ray, all three things you can show.
So position he has shown you that the position is with extension. I keep a bolster under the shoulders and the head is fixed in extension to the table. And I put the Gardner tongs before starting. The Gardner tongs were manipulation during surgery.
Do you put any weight on the tongs?
So position he has shown you that the position is with extension. I keep a bolster under the shoulders. And the head is fixed in extension. I don't think, I always feel that the Gardner tongs, if you see properly, where I fixed them in the line of the spine. If you will see when you see the proper X-ray skull with the Gardner wells, it is, can somebody take a C-arm and show them that ideally the Gardner well tongs should be in the line of the spine. I always feel that the Gardner well tongs, if you see properly, where I feel... No, we'll have to do a lateral X-ray to that. So the Gardner well tongs, I feel the purpose of the Gardner well tongs is just to see that the rotation is corrected. When I'm passing the screws, the mandible midline is in line with the suprasternal notch and it is held in that position when I want to pass the screws. You get the point I'm making? Yes. So that is the reason of the Gardner well tongs. The reduction will come more by the position in opening the joints. Now this is not a fixed AED, but in fixed AEDs, you have to work on the soft tissues between the anterior arch of the atlas and Rudrappa process. And when you remove the panels, the soft tissues, cut the longest scoli muscle, then you will get reduction.
So you put some weight on the...
No weights. You have to work on the soft tissues between the anterior arch.
So we can see on the X-ray there is good reduction.
There is good reduction. So in this position also, if we are able to pass the screws, our job is done.
And here we can also see the lower line of the mandible is above the C2-3 joint.
Correct. So that was the prerequisite for doing the case. That is a prerequisite which is available in more than 90% in my experience. That 90% of the patients, except the very kind of, there is some kind of platybasia, in which case the whole spine is, kind of impinging. There's a big, there's an angle, very almost acute angle developing between the skull base and the spine. And that is those are the kind of cases which are very difficult to do from the submandibular approach.
And Dr. Patkar, can you explain the incision also?
The incision passes exactly 1 finger depth below the angle of the mandible.
Have the camera focused on the incision?
Yeah, can somebody focus the camera on the mandible? Give me artery forceps system, one artery forceps or some instrument. From the submandibular approach. Can you see this? This is the midline. You can see the thyroid cartilage, the midline.
So the head is kept neutral or it turns?
Slide 10 degrees tilted on the other side.
Okay.
And then during surgery, sometimes I tilt it more. And this is the angle of the mandible here, and the incision, this is the anterior border sternocleidomastoid. The incision is starting from the anterior border sternocleidomastoid and turning upwards and medially. This is because sometimes the muscles are so tight that you disconnect the digastric from the corner of the hyoid. Right. But as time is passing, I stopped doing that. But today, for the sake of showing anatomy, I am going to do the dissection and show the submandibular gland, the digastric tendon, etc., etc.
So this you said is 2 centimeters below the...
Yeah, about 1 to 2 centimeters below the angle of the mandible. This is the angle of the mandible.
Right.
Can you see the artery forceps?
Yes.
This is the angle of the mandible, I can feel it. This is the mandible. And this is 1.5 to 2 centimeters below it turning up. Because the marginal mandibular nerve which supplies the angle of the mouth can sometimes get trapped in the incision.
And you always go from the right side?
Always, because I am a right-handed surgeon, so I stand on the right side of the patient. But I have done many cases from left side. For example, sometimes there is a previous kind of injury or scar. So many times I have operated from the left side also. That's not a problem. The anatomy remains the same whether you operate from right or left.
And you always go from the right side?
Unlike cervical, the subaxial spine,
where the position of the recurrent laryngeal nerve decides whether you want to go from the right or you want to go from the left.
Correct.
Injury or scar, so many times I've operated from the left. Okay, but let's get the IOBAR. The anatomy remains the same whether you operate from right or left. उसका दो पीस काटो, सीजर लो. Unlike cervical subaxial spine.
So we'll just join you in 5 minutes. We can
Yeah, sure.
quickly shift to
Mic click.
44. Correct.
Let's get the IOBAR. उसका दो पीस काटो, सीजर लो, ये काट लो.
So we'll just join you in 5 minutes. We can
Yeah, sure.
quickly shift to
Mic click.
44.
No, okay. I can adjust afterwards, don't worry. Should?
Yes, Deshpande, we are with you.
We are in the process of getting some AP X-rays and lateral X-rays because this patient is quite obese and we could feel only 2 of the spinous processes. So once the setup is ready, I will come back to you. You can go to other OT, no problem.
Okay. The X-ray appears rotated. It's
Yeah, that's why we are trying to organize it a bit.
okay. Understood.
In that, no?
So we can go to OT3 and see.
Connected, sir.
No, that was recurrent laryngeal nerve कुछ नहीं, कोई anatomy का.
And Dr. Patkar, we are back with you.
You want to do or I should do? No, you can do it. मेरे को कोई दिक्कत नहीं है फिर. वो तो कर दो फिर. After the exposure, I'll take over. Artery force.
42, you are connected, sir.
Come. Take the knife.
And Dr. Patkar, we are back with you.
Suction cartridge लगा दो. See, it is very important in this case.
41, Dr. Kolesov.
Completely preserved.
Yes, sir.
Because it can
41, you are connected, sir.
Here. After the exposure, I'll take over. Artery force. Come. Take the knife. Suction cartridge लगा दो. See, it is very important in this case.
41, Dr. Kolesov.
Completely preserved.
Yes, sir.
Because it can
41, you are connected, sir.
Here.
Dr. Kolesov?
Yes, I'm here.
Yes. So we can see the pedicles very
We have
nicely.
checked the level. And my O is T5. T5, yeah. We should go a little up.
Yes, OT2, you are connected, sir.
And Dr. Patkar, we are all waiting for you to start the incision.
Very important, that this is the cautery tip. Can you see the cautery tip? Only 2 millimeters left exposed.
Right.
Because when you are working high up, you don't want any collateral damage.
Dr. Patkar?
Because if the cautery is, not covered completely, you can touch the make-up opening in the mucosa, there's a carotid artery on one side, because you're working down, going upwards. So the cautery tip, only few millimeters should be exposed. When you're working high up,
Correct.
you don't want any collateral damage. Because if the cautery is, not covered completely, you can touch the make-up opening in the mucosa. Then we have to take the microscope. On one side, because you're let's take the microscope. Going upwards. So the cautery tip, only few millimeters. Get the microscope, so we can show on the microscope. इधर डालना है? नहीं, ये तो चालू कर दो. Microscope आएगा. The 15 number blade, sister 15 number blade and adson with forceps. Get the microscope, so we can show on the microscope. ये किधर कनेक्ट करना है? माइक्रोस्कोप आएगा. So 15 number blade, sister 15 number blade and adson with forceps. ये किधर कनेक्ट करना है? ये क्या है? इधर से. आ जाएगा ट्यूब. चलो लगा दो. ये क्या है? इधर से. चलो, you focus on this now. Come on. आ जाएगा ट्यूब चलो लगा दो so 15 number blade 15 number blade and Adson tooth forceps come on put Adson tooth forceps
कैमरा फोकस करना ऑपरेटिव फील्ड पे
हाँ चलो Adson tooth forceps so we are starting from the midline to the anterior border sternocleidomastoid 15 number blade
you have to sit there
and Adson tooth forceps come on put Adson tooth forceps
कैमरा फोकस करना ऑपरेटिव फील्ड पे
okay one more Adson tooth forceps to me cautery set करो 30-30 पे अगर वैली लैब है तो tooth forceps सिस्टर to mitigate the cautery sternocleidomastoid okay yeah जो कुछ है वो ले लो ठीक है
कैमरा कर रहा है ना वो हो ही नहीं पा रहा कैमरा मैन
you don't have a cutting one more Adson tooth forceps to me
sir we are unable to see
30-30 पे अगर वैली लैब है तो tooth forceps can you see
नो सर
the camera is not where is the camera
कैमरामैन प्लीज फोकस
camera
or you can take the microscope sir because we are not able to see
microscope रहेगा तो I'll have to show because I will not be able to assist you on the microscope so microscope लाओ the camera is not use the microscope come on
कैमरामैन प्लीज फोकस
camera
or you can take the microscope
आगे आने दो
we are not able to see
लाइट को पीछे करो microscope रहेगा तो I'll have to show because I will not be able to assist you on the microscope so microscope लाओ yeah lights on please use the microscope come on light on आगे आने दो लाइट को पीछे करो
शिफ्ट टू माइक्रोस्कोप व्यू
yeah lights on please which is focus this one sir this one is focus I use the light I know
शिफ्ट टू माइक्रोस्कोप व्यू
this is zoom mode up is coming out of zoom or going out of zoom yeah okay this one is focus yeah can take the table down a little bit one more Adson tooth sister this is zoom mode one more Adson tooth up is yeah going out of zoom yeah give me the cautery monopolar yeah okay can you see now
yes sir yes
hello
yes sir yes
so we have taken the incision and we are cutting the skin and the platysma muscle this is the platysma muscle
right
cautery monopolar okay can you see now
yes sir yes
hello
yes sir
sister I will require a stitch now after this we have taken the incision थोड़ा सा sister कम करो इसको बहुत ही कम छोटा हो गया थोड़ा निकालो and the platysma muscle this is the platysma muscle
right
pardon ठीक है not
थोड़ा बढ़ सकता है
sister I will require a stitch now after this थोड़ा सा sister कम करो इसको बहुत ही कम छोटा कर दिया हाँ चलो thank you pardon pottery हो नहीं रहा some problem ठीक है not
थोड़ा बढ़ सकता है
कर दिया हाँ thank you all right there's some error signal in that वो बैठ नहीं रहा some problem चलो ठीक है let us see वो बैठ नहीं रहा दूसरा क्वार्टर मंगाओ भैया नहीं नॉट हैपनिंग सिस्टर चलो ठीक है लेट अस सी हो रहा है क्या Error है sir. Yeah, the problem is in the cable.
No, not happening, sister.
वो switch का problem है.
हो रहा है.
So we'll quickly come back to you.
Yeah, there's a problem in the cautery, we'll get it going, then we'll call you.
Then please call us. We shift to OT3, Dr. Park.
का problem है.
Dr. Park, we are there with you.
Can you hear me?
Yes.
Yeah.
So we'll quickly come back to you.
Yeah, there's a problem in the cautery, we'll get it going, then we'll call you.
Then please call us. We shift to OT3, Dr. Park. Dr. Park, we are there with you.
Can you hear me?
Yes.
I can hear you. I can hear you.
Right.
Now everything is prepared, including level markings. I'm going to the school to wash my hand. So see you.
Can you focus the camera on Dr. Park's, what is he showing? Yes, Dr. Park.
Hello everyone. Hello, can you see?
Yes,
can you
sir,
see and can you hear me?
Yes.
I am very excited to have a live surgery. This wonderful institute, AIIMS. So now today I will do my best, and I have a plan. Definitely I have a plan. How can I do? And how can
and
I
those
do
days when I was with Ramani had this penchant that first do anterior release and then...
Dr. Patkar.
Yes, sir.
We are there with you.
No, I have not yet got the cautery going.
Thank you.
So he was asking me what is this craniovertebral surgery seen in Pune. So I said craniovertebral surgery and scoliosis surgery are surgery for poor surgeons. The canal stenosis decompression is for corporate surgeons like my friend Raja Kumar. See, his name is also Raja Kumar. Because they deal with the rich people. Craniovertebral anomaly, the patients are usually coming from some poor village, with a deformed neck, torticollis, or scoliosis also for that matter. Especially worse the scoliosis, more poor the patient. That is my theory. Because those which are early get picked up and they start going from doctor to doctor. When you get a very deformed hunchback, it is invariably a poor farmer's child from somewhere, in a remote village. And then he doesn't have money for anything, even implants you have to organize.
Correct.
So, but we are, who are we? We are surgeons, We like to live for nothing and need a reason to die for something, So we want to do more and more complex cases without any monetary incentive. But then as you grow older, now I've finished all my tenures with medical college and all. So my work is restricted to people who are paying money.
Go back to OT number 4. 44, you are connected, sir. Yes.
Thank you. Can you hear me?
Yes.
Can you see this?
Yes, sir.
More and more complex cases without any monetary incentive. But then as you grow older, now I've finished all my tenures with medical college and all. So my work is restricted to people who are paying money.
Go back to OT number 4. 44, you are connected, sir. Yes.
Thank you. Can you hear me?
Yes.
Can you see this?
Yes, sir. Yes.
For people who are not familiar with this tube, it's called an expanding tube. I want you to see here, the inside diameter is 22 mm.
Right.
Correct?
Right.
Now, this is unexpanded, and I'll expand this, okay? And it becomes double, approximately four and a half.
Okay.
Approximately. So when I want a 2-level or 3-level, I mark this is a very obese patient. I mark this at, can you see this?
Yes.
4 centimeter.
Okay.
So idea is I should land on the facet.
So 4 centimeters from the midline.
From the midline.
And this
the midline is very difficult to make, and this is
cranial is 9 o'clock.
Cranial, caudal, medial, lateral.
Okay.
I'm standing on the left side of the patient.
Okay.
And there you have this 4 centimeter, I have marked 2 centimeter above, 2 centimeter below. So I'm going to insert here, make an incision, little less first, and I can expand it whenever I want. And I land on the platysma. Hold it up. Injection?
Yes, sir.
Can you see?
Yes.
So I've cut the platysma, and after cutting the platysma, the submandibular gland is peeping at me. Can you see the submandibular gland here?
Yes.
Give me a mosquito forceps, sister. Give me a stitches of barbus linen or something. I cut the platysma. Could be there.
Yes, sir.
This is the spot.
Yes.
This is the spot. This is coagulate करो काटो, coagulate करो. Not bad. Is there? Switch किसके बाद फिर? No, I will do it. You don't worry. Just wait. और लगा दो बर्फ नहीं बड़ा मन का ये छोटा है. Can you go local sister please? Coagulate करो काटो, coagulate करो. Not bad. चलो switch किसके बाद फिर? No, I will do it. You don't worry. काट दो. Just wait. और लगा दो बर्फ नहीं बड़ा मन का ये छोटा है. Just put subcutaneous. Local sister please. It's all done. ऊपर मत करो ऊपर. हाँ बस. You're starting, ma'am. काट दिया. Yep. काट दो. नहीं अभी नहीं. Just give me the monopolar. You made this initial approximately. Yeah, mosquito लेके जा. 2.5 centimeter. You have an abdominal pad. You have like abdominal pad. Yeah, that's what. Stage है ना. Wet it can be. Stage.
44 को म्यूट कर देना.
Give me the monopolar. काटो. Monopolar. Approximately. Yeah, mosquito लेके जा. 2.5 centimeter. You have an abdominal pad. You have. बंद हो गया फिर. ये कॉटरी दरा दे रहा है यार कॉटरी.
कॉटरी काम नहीं कर रहा है.
Stage.
बाइपोलर 44 को म्यूट कर देना. बाइपोलर दो. आराम से.
काटो. नहीं तो मोनोपोल लगेगा अपने को. We can't work like this. सिस्टम मेरे को फाइन एडसन देना या आर्ट्रो ग्रुप देना हाथ में मेरे. गिव मी अ फाइन एडसन और आर्ट्रो ग्रुप. आया दे रहेगा. We can't work like this.
So what are we trying to do right now?
You're asking me?
Yes, yes, doctor.
We are at the lower pole of the mandibular gland and the cautery has stopped working. So they are trying to organize the third cautery now. So काटो इसको. Till then we will organize the bipolar. काटो. काटो please.
So what are we trying to do right now?
You're asking me?
Yes, yes, doctor.
We are at the lower pole of the mandibular gland and the cautery has stopped working. So they are trying to organize the third cautery now. चलो काटो इसको. Till then we will organize. तो स्टिच रेडी करो सिस्टर. काटो. रेडी है स्टिच. चलो इसको कट करो. काटो प्लीज. Sister, keep this ready. Ready है स्टिच. चलो इसको कट. Adson and I want a stitch ready. कॉटरी का मेरे को मोनोपोलर है क्या? चलेगा? Sister, keep this ready. Adson and I want a stitch ready. तो स्टिच देना सिस्टर. मोनोपोलर है क्या? चलेगा? इसको मस्किटो लगा खींच लो इधर. छोटा करो बस. उधर खींच लो. उधर फिक्स करो. स्टिच वापस दो. तो स्टिच देना सिस्टर. स्टिच दो वापस. इसको मस्किटो लगा खींच लो इधर. छोटा करो बस. उधर खींच लो. उधर फिक्स करो. स्टिच वापस दो. स्टिच दो वापस. अरे क्या हुआ? अरे मेरा चश्मा लगा दो यार. चारू get my spectacle there. बस. अरे मेरा चश्मा लगा दो यार. चारू या get my spectacle there. Mosquito. Mosquito. Yeah. So, mosquito. For the sake of demonstration, will reflect the submandibular gland, and the structure underneath is immediately the digastric tendon.
Okay.
Chalo, give me the cautery, please. Hold this flap. For the sake of demonstration, will reflect the submandibular gland, and the mosquito, please. Underneath is immediately the digastric tendon.
Okay.
Sister, मेरे हाथ में atro grip देना, sister. You got a atro grip forceps? Hold this flap. Atro grip. If you got a atro grip, it will be nice for me, you know. This is tooth forceps. I don't want a tooth forceps. Mosquito, please. Sister, मेरे हाथ में atro grip देना, sister. You got a atro grip forceps? Atro grip. If you got a atro grip, it will be nice for me, you know. Milaga, sister. This is tooth forceps. I don't want a tooth forceps. Give me a stitch, sister. So I am taking a stitch through the connective tissue of the submandibular gland, and that would hit the submandibular gland out of my view. All this is now unnecessary. Now I don't do this. Today I am doing it just to show you the anatomy. Come on, take this. So I am taking a stitch through the connective tissue of the submandibular gland. Mosquito, please. It hits the submandibular gland out of my view. All this is now unnecessary. Now I don't do this. Today I am doing it just to show you the anatomy. Very good. See now, the digastric tendon will come into view immediately. Can you see this?
Yes, we can.
Sister, give me scissor, please. Yeah, give me monopolar. Mosquito, please. One of the two. Monopolar, come kar do, sister.
So this is the posterior belly of the digastric.
The posterior belly of the digastric tendon. Okay, very good. See now, the digastric tendon. Can you see this? Beautifully. And here is the corner of the hyoid bone. Sister, mosquito. Please. Yeah, give me monopolar. So, this is just to show you anatomy, sister.
So this is the posterior belly of the digastric.
The posterior belly of the digastric tendon. Can you see this? Beautifully.
Yes.
And mosquito, cautery sister. No, mosquito. So, this is just to show you anatomy. Keep the monopolar minimum, Mosquito.
So do you retract the digastric or you cut it, sir?
If the situation is tight, I'll disconnect it from the higher bone. But most of the time it is not required.
And if you disconnect it, you resuture it back? You just...
I resuture it, but even if sometimes when I'm not done, nothing happens.
So do you retract the digastric or you cut it, sir?
If the situation is tight, I'll disconnect it from the higher bone.
Okay.
Just dissect it because you don't know what structure is there.
And if you disconnect it, you resuture it back? Or you just...
I resuture it, but even if sometimes when I'm not done, nothing happens.
The hypoglossal will be...
It will be under the digastric. When I mobilize the digastric, I'll see the hypoglossal. I don't want to go there.
Right.
Like the recurrent laryngeal nerve. If you don't search for it, it does not create trouble.
Right.
If you demonstrate where it is, then you come in trouble. Sister, mala atrogrip I need an atrogrip basis.
The hypoglossal will
be... No, give it to me left. So then I put my finger and I feel the carotid. I don't want to go there.
Right.
Like the recurrent laryngeal nerve. If you don't search for it, it does not... So here I can feel the carotid. Can you see the pulsation also? Then you come in trouble. Sister, mala atrogrip I need an atrogrip.
Not really, sir, but we can...
See, I will ask Dodamani to confirm it. Dodamani? So then I put
no, but we believe this is...
the carotid.
We believe you, sir.
You believe me. You should not believe me. There should be evidence to believe me. Give me scissor, sister. Can you see the pulsation also? So this is the plane I was searching for. See, I will ask Dodamani to confirm it. Dodamani, you are getting the point? Now I got the plane. See, when I put my finger down, I'm feeling the spine. Put your finger down here. Give me scissor, sister. Tighten it.
The vertical part of the incision, vertical limb, is it required to be extended or you just kept it as a backup?
There is no need to extend the incision now.
Okay.
I didn't get your question. Can you repeat your question?
There were two limbs which were drawn on the skin, sir. One was the transverse and one was the vertical.
No, there is only one.
Incision, vertical limb.
Sternocleidomastoid, that is sternocleidomastoid, anterior border is sternocleidomastoid.
Okay.
To decide the posterior extent of my incision.
Okay.
That was the
I didn't get
Can you repeat your question?
There were two limbs
Can you feel the spine?
which were drawn on the skin.
Okay.
One was
Now, if you are technically correct, we will be somewhere on the C2-3 disc or on the body of the C2. No? Now, get the right angle retractor system. Give me mosquito, please. The posterior extent of my incision. No, मैंने जो लाया ना.
Understood, understood.
Okay. Can you feel the spine? Okay. Now, if you are technically correct, we will be somewhere on the C2.
43 are connected. Dr. Patkar will just join you in 5 minutes.
Yes,
Dr. Park.
No, मैंने जो लाया ना.
43 are connected. Dr. Patkar will just join you in 5 minutes. Yes, Dr. Park.
Caesar. Caesar.
Dr. Park.
Something. What to, yeah.
Yes, Dr. Park.
I can hear you. I can hear you.
Okay. So please, can you tell us what you're doing?
Yes, yes. I am putting after the completing triangulation on the L2 lamina. I am putting the trocar. Okay. So can you just write a smaller bar? Okay. For the good outflow, I made a skin incision, bigger skin incision. Usually 1.5 cm is optimal. I made a very small skin incision, about 2 cm. This is some vessel. I don't want to sacrifice vessel. I'm going to go about bipolar cautery, please. Yeah.
Yes, Dr. Patkar.
So we have reached the spine. Now we are going to confirm where we are on the spine. Okay. Cautery come karo bhaiya. Cautery come karo.
Make it 10.
What?
Can you center the image?
I don't want to sacrifice vessel. I'm going to go about bipolar cautery, please.
Yes,
Can you see now?
Yes, yes.
So I'm on the spine now. I'm going to take confirmatory X-ray. And if I'm correct, I'm on the body of C2, you know. Give me cautery come kiya? कितने पे?
15.
Oh, very good.
Can you center the image?
और कम करो. Can you see now?
Yes, yes.
So sister, give me a QR. Give me a QR, sister. Correct. I'm on the body. QR. Give me cautery come kiya?
Yes, sir.
Maybe, but I'm not going to spend time because that is why I don't like to dissect from above below too much, you know. Give me QR. QR, sister. Give me a QR. On the right angle, please. Give me a QR, sister. Pardon? Hypogloss will be above. No. Give me monopolar. Spend time because that is why I don't like to dissect from above below too much, you know. No, don't try to search for it. Then it will not create any trouble for you. QR Manka. One more right angle, please. Pardon? Hypogloss will be above. No. Give me monopolar. Sister, I want a QR soon. So these are the two longest scalar muscles you are seeing them, you know. No, don't try to search for it. Yes, sir.
I'm sorry, Visocchi, Massimiliano Visocchi.
Pardon?
Did you detach the tendon of the gastric muscle? We didn't see it.
No, I did not.
You did not.
I did not. I was telling him that nowadays I don't do that. So this is the longest scala, yeah, that's right. So we take the longest scala aside. Yes, give me the cautery, sister.
So you are lateral to the horn of the hyoid bone, right?
Pardon?
Lateral to the hyoid bone.
Yeah, I'm lateral to the hyoid bone. I was telling him that nowadays I don't do that. So this is the longest. Okay, now I want a KR. I just want to confirm where I am. So I can get, this is looking like a disc to me here, this might be a C23 disc. Can you see that?
Of the yoid bone.
Your eye, please. Is it a disc, no?
Lateral to the hyoid bone.
Yeah, I'm lateral to the hyoid bone. Give me a hammer, please. So this, if I'm right, is, that's all right, I'm not putting the disc. So I can get, this is hammer, hammer. To me here, this might be a C23 disc. Can you see that? Your eye, please. Okay, ask for a Siam. Remove that. Remove it. Give me a hammer, please. Remove it. So this, let's do a Siam and check where we are, so then I can proceed with my dissection. I think I'm onto the anterior surface of the C2.
Right.
I just want to confirm that with the Siam image before I do more dissection. Remove that. Remove that. Let's do a Siam and check where we are, so then I can proceed.
We can
with
shift
my
to
dissection.
OT4, Dr. Patkar.
I think I'm onto the anterior surface of the C2. I just want to confirm that with the Siam image before I do more dissection.
We can shift to OT4, Dr. Patkar. Dr. Patkar, we have, sorry, Dr. Deshpande, we are with you.
Organize a bit of this initial dissection.
You are connected, sir.
I'm not connected?
Yes, sir. Yes, Dr. Deshpande.
So what I'm trying to do is I'm trying to land this quadrant onto the facet joint here.
Right.
Now the facet joint is about a centimeter inside and my tubes are short. So I'll have to end up with a little bit of dissection here, but I'll get to it. Once I expose the facet, I can call you guys?
Sure. We'll shift.
This is the one. I need this. So how will I do that? Yeah, this tube is short here. By 1
So there's a
centimeter.
question, Dr. Deshpande.
Yeah?
There's a question from the audience that what made you remove the tubular retractor which you placed?
No.
What's,
What is the question again, please?
but you had put in a tubular retractor.
The reason is I want to land on the facet.
Right.
If I land on the facet a little medial lateral, I want to make sure that I should be bang on the target, that is the facet. I can adjust it either by moving like this,
right,
or a little angulation.
Okay.
But if you see the tube, the end of the tube is here, but the facet is a little at a depth, about a centimeter.
Okay, so we'll reposition.
Dr.
Patkar, we are there with you.
And see the best possible.
Understood.
Okay?
We go
To
back
confirm the position of the needle, which we have tapped into the anterior surface of the C2 body.
Yes.
So once that is confirmed, then we can boldly get on with the work, you know.
So X-ray has still to be done.
we are there with done.
X-ray has not been done with the
We are doing it just now. The technician was not there. He has come.
So we quickly shift to OT3.
So once that is
OT3.
confirmed, then we can get on with the work, you know.
So X-ray has still to be done.
Pardon?
X-ray has not been done with the
We are doing it just now. The technician was not there. He has come.
So we quickly shift to OT3. OT3. Dr.
Elevator place. Go higher. Yes.
Yes, we can see that you have a good flow.
Yeah. Outflow is good. But the endoscope is not clear, just like yesterday.
Yes.
But no, don't touch. Okay. Yeah, breathe. This is the intralaminar space. Now I'm starting the release of intralaminar space. You know very well. Here you go. Here is a 2-3 interlaminar space. You have to remove L2 lamina.
Right.
Okay.
So will you remove the whole lamina or just the undersurface of the lamina?
Can you see the lamina over here?
Yes.
And I am telling you, this is L2 lamina, okay?
Right.
So my goal is having left side heavy anatomy to expose the dura, and I would like to preserve the midline structure.
Okay.
So for the stability, so this is L2 lamina, okay. Because ligament problem is a wonderful protection barrier to the injury. So you always try to use your ligament problem as a protection barrier for the never injury from the wrist.
Can you orient us to what is cradle and caudal?
Okay. 6 o'clock, 9 o'clock is head, okay? 12 o'clock is the midline, and 3 o'clock is the coda, 3 o'clock is the leg,
right?
And 6 o'clock is the operation site, ipsilateral. So we are near the upper interlaminar space. Here is a upper 1-2 interlaminar space here, 2-3, 2-3. 1, 2, okay. And here we are looking for the midline, okay? Carry 2, 3. 1, 2, okay, you can see the epidural pad here, coagulation.
Yes.
Coagulation. This is the head of butterfly, okay? When you find the first epidural pad, here is the midline cutting. So we made the technique for the butterfly ligament problem removal. I call here head of butterfly coagulation. Okay, good. So you have to I'm doing contralateral sublaminar drillings to expose epidural space. So because epidural space is open,
Dr. Patkar? Yes, sir. See the C-arm. We are on the anterior body, we are past the KY. Right. And the KY is on the anterior border of the C2 at the lower end. Just above the C2-3 disc. Can you see it?
We go to OT2.
Can you see it?
We are seeing the microscope view. Dr. Patkar?
Yes, sir. The X-ray दिखा भैया. We are on the anterior border, we are past the KY.
Right.
And the KY is on the anterior border of the C2
Right, sir. We
at
can
the
see
lower
it.
end.
Just above the C2.
मेरे हाथ में section दे भैया.
Can you see it?
ये पकड़ लो ऐसे, ये पकड़ो. ये section monopolar दे दो.
We are seeing the...
So this is the opening which we have done in the body of the C2. Now I am going up and I am going to separate on top. And the C1 C2 joint is apparently 1.5 centimeters above. Because I had seen yesterday.
So this is the opening which we have done in the
Monopolar system.
Now I am going up and I am going to separate.
The longest fillet you cut like we do in cervical disc, or you cut it transversely, sir?
No, I only cut the medial half of the longest scapula when I reach the level of the joint.
Seen yesterday.
Monopolar system.
We are at the midline.
So one of the audiences asked a question, ki, would you prefer nasal intubation?
Does not make a difference to me. Because I am much above, no?
Right.
So this is the longest school, I must say. You can see the longest school. Give me the molecular sister.
So one of the
Yeah,
audiences asked the question, ki, would you prefer nasal intubation?
See? Does not make a difference to me. Okay?
Yes, yes.
Can you see now?
The longest coli on the...
This is the longest coli on the right side.
Yes.
This was the needle.
Right.
Where I passed.
Right.
As per the yesterday's study on the CT scan, the odontoid begins about 1.5 centimeters. So from year to year, this must be the beginning of the odontoid process, you know.
Right.
And here I will get the anterior atlas. Where I passed.
Right.
As per yesterday's study on the CT scan. Yeah.
So how later do we dissect out the longest coli?
To expose it, I should be able to see the entire joint, you know.
The entire joint. Right.
So now I am reaching almost the anterior arch of the atlas here. Here is the anterior arch of the atlas. I can feel it with my instrument. I will show you.
So how later do we dissect out the longest?
So now you see the opposite longest coli muscle also.
Yes.
So it is always easier to start the dissection on the opposite side. And you will see the joint over here because I am exactly 1.5 to 2 centimeters above. So I will get the joint over here. Sister, give me the monopolar, please. One minute. What was the cautery Dr. Sarat Chandra was using yesterday? Is it the same cautery?
No, sir. That was molecular resonance, sir.
Huh?
That.
Vasilievich.
Yes, sir.
Vasilievich. He was a great anatomist. It was Vasilievich who purchased the body of his servant.
No, sir. That was molecular resonance.
ये Vasilievich है?
That.
कौन सा पेड़ है? ये है ना? अच्छा ये किस? अच्छा ये Vasilievich है क्या? It was Vasilievich who purchased the body of his servant. हो नहीं रहा. It is not happening, but. ये Vasilievich है? हो नहीं रहा Vasilievich. कौन सा पेड़ है? ये है ना? अच्छा ये किस? Yes, now it is happening. Very good. Amazing, what? Amazing. ये कितने को मिलता है लेकिन ये? 50 lakh. Oh my God. Costly, very less. Yes. Right? बहुत कम है cost. Amazing, what? Amazing. पानी डालो थोड़ा. 50 lakh. Oh my God. Costly, very less. Right? बहुत कम है cost.
So we can start seeing the. Can you center again, Dr. Patkar? We can see the what we think is the joint now.
You're asking me?
Yes.
Yeah, I'm reaching the joint now.
Can we center it?
Yeah, I'll do that.
So we can start seeing the.
Okay.
Can you center again, Dr. Patkar?
Sister.
We can see the what we think is the joint now.
You're asking me?
Yes.
Yeah, I'm reaching the joint now.
Can we center it?
Yeah, I'll do that. Under here.
Yes.
Okay. On the facet, superior facet, you know. Yeah, I am very much impressed with this cautery here.
So that's the reason everybody doesn't get it.
Everybody doesn't get to do it, huh? Under here.
Only privileged people.
हाँ, सिर्फ सीजर देंगे वो जरा ये लिगामेंट इसका पैड वगैरह निकाल देंगे बीच में आ रहा है ये मेरे को I'm very much impressed with this cautery. Yeah, this is a part of the anterior longus ligament with the longus colon. Everybody doesn't get to do it, huh? Just give me a biopsy process. हाँ, सिर्फ सीजर देंगे वो जरा ये ligament. So give me the bipolar. go here. Yeah, this is a part of the anterior longus ligament with the longus colon. Sister, give me a biopsy process. Yeah. Yeah. Give me the. I don't know that. I need to tilt this a little bit. Just hold this. I will tilt the microscope now. Yes, sir. Question. Bipolar system. I need to tilt this a little bit. Just hold this. I will tilt the microscope now. Yes, sir. Question. Bipolar system. Just 1 minute.
That is the superior surface of the joint?
Of the superior. Just a second. Give me monopolar system. No, just 1 minute.
That is the superior surface of the joint?
Of the superior. Just a second. Give me monopolar system. Yeah. See this is the superior facet of C2. Can you see the superior facet of C2?
Yes, yes.
See this. Now sister, just give me something to put. This is the cartilage. You can see the surface, the cartilage.
Yes.
In the joint. I am already in the joint. And you remember that the joint is not horizontal. The joint is inclined laterally. So anything above the joint, any bone that is filled above the joint is nothing else than the lateral mass of the atlas. Just as any bone that is lateral, superior lateral to the root is the pedicle in the lumbar spine.
Is there any chances of being near the vertebral?
No, the vertebral is still lateral. We studied the CT scan lateral,
right?
And the vertebral was far away from us. And what you are seeing now, see this, the entire joint surface. Can you see the joint surface?
Yes, very nice.
And this bone on top is the atlas. This is the lateral mass of the atlas. We studied the CT scan lateral. Sister, give me the scissor, please, or give me a blade. Far away from us. See now, see this, the entire joint surface. Can you see the joint surface? Give me 15 knife, sister. And this bone on top is the atlas. This is the lateral mass of the atlas. ठीक है, अभी तो पूरा भी ठीक है. Sister, give me the scissor, please, or give me a blade. So I am cutting the ALL and the soft tissue on top of the joint surface, you know. Give me 15 knife, sister. Give me bipolar. ठीक है, अभी तो पूरा भी ठीक है. So I am cutting the ALL and the soft tissue on top of the joint surface. Give me your biopsy process, sister. Biopsy process. Give me bipolar. Bipolar. Give me your biopsy process, sister. Without money, you are appreciating now the joint very well.
How medially do we go, Dr. Patkar?
Pardon?
How much medially do we go?
No, we go right up to the midline and laterally until we expose the whole joint, you know. See, this is the one facet.
How medially do we go?
No, when I pass a screw, keep this and pass a screw and the screw will go nowhere else except into the lateral mass of the C1. So let me clear the anterior surface of the C1. See, this is all the lateral anterior surface of the C1. Can you appreciate it?
Once you clear this tissue, yes, now we can.
Can you see now the C1 lateral mass?
Yes, we can.
Except into the lateral mass of the C1. This is the entire. Now I know where the lateral mass of C1 is going in which direction. See, this is the entire square bone of the lateral mass of the C1.
Right. Once to clear this tissue. Yes, now we can.
Can you see now the C1 lateral mass?
Yes, we can.
This is the entire. Now I know where the lateral mass of C1 is going, in which direction. Now, to say that the position is correct, the C1 and C2 must be in the same plane, you know. And the bipolar, yeah. Pardon? Now, to say that the position is correct, the C1 and C2 must be in the same plane. Do you see now? The entire this has been exposed. Now, there is a little rotation because we have tilted the head. We have to make it straight, you know. Yeah, see this. Yeah. See now I exposed completely. Can you see this is the beginning of the entire process? Okay? Yeah, you can see now the entire process. See this. See this. Can you appreciate?
Yes.
Now let me come on this side.
Can I ask you a question, Dr. Patkar?
Yes, sir.
Yeah. The structure we appreciate at the bottom of the right is the hypoglossal vessel.
Can you appreciate?
Hypoglossal artery. Can I ask you a question or not?
Yes, sir.
That one, right.
Which is this one? Maybe, but it is far away from me.
Yes.
So I'm not spending time to search where it is coming and where it is going. But it is there, it is far away from me, nothing to worry.
I see. So you don't isolate at all?
No, don't. If you spend time exposing it, there is a chance that you might injure something monopolar. But it is far away from me.
And laterally, what about sympathetic branch?
What about sympathetic chain? I think that is also along with the carotid artery and far away. No, don't. If you spend time exposing it, there is a chance that you might injure something monopolar.
So you didn't detach tendon of the gastric nerve, didn't isolate hypoglossal nerve, just spread laterally?
Just went laterally, didn't spend time searching for it. Previously I used to search for it.
Yeah.
You know, and then I used to sometimes end up in neuropraxia. Nowadays I don't spend time searching for it. I just proceed with my work, you know.
Hypoglossal nerve just spread laterally.
Just went laterally, didn't spend time searching for it. Previously I used to search for it.
Yeah.
You know, and then I used to sometimes... So I'm cutting a little bit of longer scoli now. Nowadays I don't spend time searching for it. I just proceed with my work, you know. So I'm cutting a little bit of longer scoli now.
Sir, before putting the screw, please let us know.
Yeah.
We'll come back to you.
Sure, sure. After I finish my dissection, I'll call you.
Right, sir. So we go to Dr. Park.
Yes.
Please. Dr. Park, we are there with you. Sir, before putting the screw, please let us know.
Yeah.
We'll come back to you.
Sure, sure. After I finish my dissection, I'll call you.
Right, sir. So we go to Dr. Park.
Yes.
Please. Dr. Park, we are there with you.
Yes, yes.
Please tell us what you're doing.
Sure. So, yeah, I cannot understand your talk. What's going on? Oh, yeah. I'm exposing to the coagulation. Here, coagulation. Power, full power. No fluid. Open, opposite side. Coagulation. Not working. Cutting. Stop.
Why is the view not so clear, Dr. Park?
Coagulation. Yeah. I don't know. Maybe it is a problem of endoscope.
Okay.
This the condition of endoscope is the same as yesterday.
Yes.
So it is a problem. And because view is not good, so I am exposing dura like this. Can you see white color here?
Yes.
This is a dura,
Right.
and 12 o'clock is a contralateral margin of dura. So after exposure of dura, I will open the durotomy, okay? Punch. So I'm trying, you can see the movement of soft tissue. Movement of soft tissue means outflow is good.
Yes.
So if outflow has a problem, we cannot see anything because of bleedings. So because we can see the movement fluid and we can have visions. It means relatively outflow is good. Only I am focusing on is maintaining good outflow. This is a contralateral. Here is a contralateral dura here. And here I am exposing. We are now exposing the joint on the opposite side, and we have exposed the joint a little bit on this side. I will show you the joint within 2 minutes.
We'll go back to OT2. Yes, Dr. Patkar.
So we are now exposing the joint on the opposite side, and we have exposed the joint a little bit on this side. I will show you the joint within 2 minutes. Bipolar system. You can see the atlas. Can you see the lateral mass of the atlas?
Yes.
Bipolar system. So that is the entire lateral mass of the atlas. And this is the facet of the C2, no? You can see the atlas. Can you see the lateral more laterally?
Yes.
So that is the entire lateral mass of the atlas. And this is the facet of the C2, no? So I want to go a little more laterally. Go a little more laterally. Sister, give me a dissector, please, or something, some instrument to palpate. Yeah, we drill this. You can do retropharyngeal odontod also. There's no problem. Bipolar. We should not do. I don't think we should do transfer odontod. Sister, give me yeah, people are not comfortable because they are not using microscope to expose this, you know. Once you use microscope to expose this, see, within how much time we were already on the joints. We should not do. I don't think we should do transfer. Yeah, because they have not attempted this approach. Not comfortable because they are not using. Once neurosurgeon attempt this approach, they will stop doing. Once you use microscope to expose this, see, within how much time we will सामने odontod joints. Why take all that risk? Yeah, because they have not attempted this. इसका right angle ठीक करो यार. Once neurosurgeon attempt this approach, they will stop doing. ये इधर सामने odontod. Why take all that risk? So now, इसका right angle ठीक करो यार. इधर.
कटिंग कितने पे है सिस्टर मोनोपोलर? पट्टी कर दीजिए.
So now,
30. कटिंग कितने पे है सिस्टर मोनोपोलर?
1 minute. Just give me some time, before I make my decision what I'm doing. I'm getting lost in the anatomy for some time. This is not a new case, This is an old case because there has been a scar formation, 1 minute. Yeah, I'm still not seeing C1 facet properly. Make my decision what I'm doing. I'm getting lost in the anatomy for some time. This is a biopsy for some new case, This is an old case because there has been a scar formation, This is a छोटा लगा biopsy for the. Yeah, see, this is the joint. You can see the joint, no? Monopolar system. This is a biopsy for some. बराबर नहीं मानो
Yeah, Sushil, you need to excise this old tissue, yeah.
Yeah, there is a lot of panels, no, because this is a very old injury. This injury is almost 6 months old, So, lot of kind of, fibrous healing has taken place.
Yeah, Sushil, you need to excise this old tissue, yeah.
Yeah, there is a lot of panels, no, because this is a very old injury. This injury is you are appreciating now? Old, See, this is the joint we have exposed. So, lot of kind of, fibrous healing has taken place. Give me that bipolar system. You are appreciating now? See, this is the joint we have exposed. Give me that bipolar. This is the facet. Now, so far we were not on the facet, Now you can see the facet. This is the facet. Now, so far we were not on the facet, Now you can see the facet. Yeah, that is why he's struggling. Give it to me. Yes.
You need to dissect ipsilateral side because you have tendency to go to opposite side.
This is the atlas. Bring it down here. Yeah, that is why he's struggling. Give it to me.
You need to dissect ipsilateral side because you have
Now
tendency to
well
go to opposite side.
Give me monopolar, sister. Bring it down here.
Yeah.
Suction. That's a fun. See, now it is well seen. The facet is here. Give me monopolar, sister.
So this joint is more lateral than we thought it's.
Yeah.
No, ipsilateral you tend to miss.
Yes.
So you tend to go to opposite side.
Yes, parallax.
I'll check. Give it to me. You can hold another suction there, darling. I need one suction here.
So this joint is more
Bipolar
lateral than
too.
we thought it's.
Yeah.
Ipsilateral you tend to miss.
Yes.
So you tend to go to opposite side.
Yes,
ले जाओ उसको suction. I'll check. Give it to me. You can hold another suction there, darling. I need one suction. Cautery कम करो. Bipolar too. 20 करो 20. Give me monopolar, bipolar. इसका bipolar कौन सा black है ना?
Hello, 44 you are connected, sir.
Yes.
44.
Yes. Can you see, please? Yes, we can see.
Give me monopolar, bipolar. इसका bipolar कौन सा black है ना?
Hello, 44 you are connected, sir.
Yes.
44.
Yes. Can you see, please? Yes, we can see. This is the facet of. Can you just orient
S1.
us with the S1 cranial?
So let me explain again. Let me unzoom.
Yes.
So this is the medial side of the patient.
Right.
This is the lateral.
Right.
Inferior, superior.
Right.
Now I have some challenge in this particular patient because of the way the table and construct is there. It should be a little bit more like this, but because the holder is there, it's moving. It's okay. But can you see the S1 here?
Right.
This is the L5 S1 facet. Can you see the movement here?
Yes, yes.
Okay? The L4 file will be somewhere here, forget it. This is L5 S1. So I want to make a cut here and take out this bit and take out this bit. Then I'll be in the L5 S1 Cambin's area. Okay?
Okay. Can you just point out the pars interarticularis?
Yeah, that's the challenge here. There is some movement here. Can you see it here?
Yes.
So I'm not sure where this, but when I take out, I can show better.
Okay, okay.
Are you clear now?
Yes, yes.
So I can just zoom it. I just made this. And I also want to understand one thing. From here to here is 8 centimeters.
Okay, so deep.
So it is really very obese patient, 8 centimeter from here to here. Okay?
Right.
Give me a monopolar, please. Okay. So give me a chisel. You have a chisel. And you can give me a regular chisel, yeah. Narrow chisel. ये बड़ा है. Narrow. Show me this. Yeah, this is great. And give me a. Can you give me a mallet?
So this first cut is on the.
I'm trying to take out it in a. The first cut should have been like this, but there's a parts defect.
Okay.
I don't want to go there. I'll
Right.
take out in piecemeals like this. So can you see the gap there now?
Yes.
So I'm being very gentle. I don't want to be. In the regular case, I can be harsher.
So this is the inferior articular facet
Yeah.
of L5.
Yeah.
Okay. Pars is already defective, so you have not.
No, you give me a disc forceps. You have? You have a regular disc forceps, huh? Straight. Yeah, this is good. Keep the bone. Keep the bone. Keep the bone. The bone should be kept, sister. Don't discard it. You have a slightly bigger one than this. You have a slightly bigger than this. Yeah, give that please. Basically, I want this to go. Can you see it now? The whole thing is moving there. Can you see it now? Huh? Be gentle, huh? Don't be in a hurry to finish the case. Leave it. Take out the suction. So can you give me a forceps? Suction to me, sir.
Dr. Patkar?
Yes, sir. We have finished exposing both the joints, subclassical regions and the atlas. Now we have tilted the head and fixed the head. We want to remove that fixation so that when we are looking, the facet joints are in the same straight line and that the atlantoaxial dislocation has got corrected.
How have you fixed the head, sir?
With a sticking plaster. We have a very famous gadget in Mumbai side. It is called chicken patti. Chicken patti. Chicken patti means sticking. Chikat means sticking.
Okay.
Patti means tape. The atlantoaxial dislocation.
So you have fixed the.
Head in extension and rotation to the opposite side.
Sticking plaster.
Let him cut it. In Mumbai side, it is called chicken patti. Chicken patti.
Can you just de-zoom and show us the position, sir, on the...
Yeah.
So you have fixed the
Head in extension to the opposite side.
Okay.
इसको उठाओ ना ऊपर यार वो चिकन पट्टी जो है ना वाइट कलर का दोनों दिख रहा है आपको
नहीं we are just microscope
पेशेंट को मत काटो कोई ट्यूब मत काटो चलो क्या करोगे काट दिया ऊपर यार वो चिकन पट्टी जो है ना वाइट कलर का दोनों वो द सेम वाइट बॉय नॉट देयर ना व्हेन यू पुट जो बंदा वही थिएटर में रहे मत काटो कोई ट्यूब मत काटो दोनों काट दिया चलो ठीक है अभी लेट्स यस नाउ टर्न द हेड मेक द हेड स्ट्रेट वेट टिल अभी लेट्स पुट द retractor right angle retractors right angle
You have made the head neutral again.
yes we have made it neutral again now we are going to go and see what is the situation inside चलो ठीक है अभी लेट्स yes now turn the head make the head straight wait till let's put the retractor right angle retractors right angle
you have made the head neutral again.
yeah you can raise this capital see now hold this now you can see the atlas and this facet they are just over each other can you appreciate
Yes. Can you focus?
I'll just focus now yeah you can raise this capital see now hold this section. Now you can see the atlas and this facet. They are just over each other. Can you appreciate?
Yes. Can you focus?
I'll just focus now. See this. This is lateral mass section. This is a facet.
Right.
Okay?
This was the ledge which was seen on the...
Correct. So we have to fix it little on that side, and we're pushing this in the this is the position. So see, I'm reducing the atlantoaxial dislocation with the retractor, which is pressing on the lateral mass of the atlas. Okay. Can you appreciate?
Yes.
When I remove it, I'll send it to you. Hold this. And we're pushing this in the this is the position. So see, I'm pushing. Is it centered now? Yes. Okay. Now appreciate one thing. See, after you release everything, what you can do, we press this. We are brought in the same plane.
Yes.
The facet, the lateral mass of the atlas and the superior facet are in the same vertical plane. You can see Sahyadri plane. So when I pass the screw, they will be fixed in the same Sahyadri plane. After you release everything, you get what I'm saying?
Yes. So you push down with your retractor?
That's right, with my retractor.
Yes. You push down on the...
Whichever, the atlas is the one which is usually in the front.
Right.
So you push down and bring it. No, that's see, it is getting dislocated. This is the position. See, now they are both in the same plane and we pass the screw like this. That will be the plane of reduction. Now let us see the other joint also.
Push down on the...
Now that we have brought this in neutral, let us study the other joint. What is the situation in the other joint? Doctor. Hold this. This is the position. See, now they are both in the same plane and we'll pass the screw like this. That will be the plane of reduction. Now let us see the other joint also. Now that section we have let us study the other joint. What is the situation in the other joint? Doctor. This is. One minute, पूरा अंदर जाना नहीं तो section control मेरा sister. देखो. Yes. So now you can see this facet.
Yes.
Okay, this is superior facet, this is inferior facet. I'll pass the screw will go nowhere else but into the lateral mass of C1. And they are in the same plane. Okay. Yes.
So first you will put on the equilateral side.
Opposite side. The opposite side is always easier.
Okay.
So from here to here, it is very easy for me to put the screw. I have to first put it and see whether the reduction which I wanted is available or not available. You know? And if the joint is open, I'll curate the joint and take some bone grafts from the iliac crest. Show me my curate system. Now just I'll show you the curates which I brought. It is very easy for me to put the screw. There is an array of curates, downward pointing, upward pointing. Can you see them? Can you see?
Yes, yes, we can see.
And where the other curate system? Just the standard carving, you know, which is downward pointed. So that is used to prepare the joint. There is an array of curates. So now I can even put the drill, but I prefer to use this series. Can you see?
Yes, yes, we can see.
And where the other curate system? And remember, this is not like a regular like knee joint or something with a synovial and all inside. There is, people talk about capsule, but I don't think that the atlantoaxial joint has any restricting capsule. Hardly a very flimsy membrane. And even if you just make a little this in the cortex, you violate the cortex, it is going to start fusing. See this? It is gone inside for more than a centimeter and I pull out and I am preparing the cortex on the superior surface. So sister did the other curate will be directed upwards. Just make a little this in the cortex, you violate the cortex, the other one. Up curate, no? Inside for more than a centimeter and I pull out. And I'm preparing the cortex. So this I'm making, violating the other curate which is directed upwards. End plate, you know. And once you violate the end plate, nothing else but bone will start growing from it into the bone graft that I put. And see this. You have to remember that the joints are inclined laterally, they are not straight downwards. They are inclined laterally. You understand? That is why when you pass the screws from behind, you always direct the screws immediately. Right. And therefore, when you curate also, you should remember that your curate should go laterally. You have to remember that the joints are inclined laterally, they are not straight downwards. They are inclined laterally. You understand? That is why when you pass the screws from behind, you always direct the screws immediately. Right. And therefore, when you curate also, you should remember that your curate should go laterally. Well, sister Apollo curate them. So you see how safely you can garden the joints when you are working from behind, because there is no fear. Now I am getting this grating sensation all throughout.
So we'll join you in a minute.
Yes, sure.
We'll shift to OT1.
Yes.
Dr. Kolesov?
Yeah. So, you see how safely you can garden the joints when you are working from behind, because there is no fear. Now I am getting this grating sensation all throughout.
So we'll join you in a minute.
Yes, sure.
We'll shift to OT1.
Yes.
Dr. Kolesov?
Yeah.
We are there with you.
Yes.
Tell us what have you done so far?
I'm introducing critical screws on the apex of the concave side.
Okay.
Deformation very medial, in long position, almost straight. And
so you will still go ahead with the pontiff osteotomy?
Maybe a little.
Okay.
A little. Because very medial. I think 45. Good.
Okay, we shift to OT4.
Can you hear me?
Yes, we can.
So what I have done is I just removed the facet here.
Right.
The facet is removed. You can see part of the facet. Lamina is still there.
Right.
I removed the, show me that piece of bone I just removed now. Give it to me, keep it here. The big piece of bone, give it here. So, you can remove the inferior facet, it was like this.
Right.
I just taken it out. Now, I want to identify the superior aspect of the pedicle of S1, which is somewhere here.
Give me a hook. Of course, widen this whole area. Hook, please. So, this is the SAP, and this is the area of the S1.
Right.
Pedicle, right?
Right.
So up to that I can easily take off. Give me a chisel. Oops, it's angulating down. Just gently shave this off like this. Get as much bone as possible. Okay. Yeah, and give me a drill. All neurosurgeons should learn fine drilling. Drilling. How much to drill, what area to drill, anatomically. Give me a hook.
Are you trying to feel for the pedicles?
Yeah, I'm trying to feel for the pedicle. Pedicle is here. Yeah, see, this is the medial aspect and this is the pedicle here. Okay? Drill please. So the idea is to be at the level of the superior auricular facet drilling. Yeah?
44, 3, 44, 3,
Okay, sir,
let's just join you. 44,
Which
43,
way
sir.
is the best?
43,
Okay, looking
yes.
for.
Dr. Park,
Yes, yes.
We are there with you.
Yeah, we make a copias. So we have a big hope. Yeah, we made a Tony, and I'm looking for the tuner. But it's a 30 degree, so it's not easy.
So dural incision you have made?
Yes, yes, already made. And you can see the root rod here. Yes. And looking for the tumor. Tony, and the root rod is here, double M. Making Tony, and I'm looking for the tumor here. So we can use this retractor, like this, gently retract here, like this. Move to here. We know very well, this is okay, because this is okay, I know dissection and okay, and I think that this way is, reduce the input, reduce the fluid input, reduce the fluid input, please, and give me pad, cotton please, make a cutting.
you have to take care, circle, okay? Don't touch it. Because it is a 30 degree, okay? One more 0 degree. Try it, okay? Try it.
So tumor, have we seen the tumor? Dr. Park?
Yes?
Tumor is visible or not?
But I don't know what to say. Sorry, speak again.
Could you see the tumor?
Yeah, I found tumor. And I will dissect tumor, but this is 30 degree. Give me 3 minutes, 5 minutes. I will make beautiful and call you again. I'm changing the endoscope. Try it.
So previously you were using 0 degrees.
Yeah.
Now
the quality of 0 degree is so bad. I changed the 30 degree. The vision become good, but I'm not familiar with the 30 degree, so I'm changing 0 degree again.
Again 0 degree.
Okay. I think we can find off. Okay. Connected. Everything connected. Okay. And what input what? And auto focus. White balance. White balance. Put white balance.
Reverse screwed up. Yes, sir. So the joint is prepared. We are ready now. Now we are going to pass a QR and just see the trajectory and confirm that we are going in the right direction.
Oh, that's great.
चलो केयर मेरे को little bit the system.
I think
Patkar sir, I had a question.
Yes, please.
Sir, how do you know that the joint is adequately prepared? I suppose even on SUI2 is convex and convex joint. So you are doing it with the curettes. So what is the end point that you know that you have to stop?
I got curettes which are of 1 to 1.5 centimeters in length at right angle.
Sir, how?
And they are not what they without this kind of curette like this, you know. You see this curette?
Convex and convex.
See this? But this is not the correct one for this case. I could not get my curettes there in the OT, and there was somebody had a case, and now I stopped having my own instruments. They are hospital instruments. So I have to listen to that you can't take them. This would not have happened 20 years ago, you know. Serious. So I got curettes which will go down for about 1.5 centimeters inside. I measure the length of the joint on the CT scan also. It is usually between 1.5 to 2 centimeters, very rarely more than 2 centimeters. So you must be able to go inside for a significant amount of length to curette. See this now? I am getting this grating sound everywhere, you know. I measure the confirm you can hear it or not? The grating. Hello? So tell them that there is a grating sound, which means that the joint has been prepared, you know. Please. Now we have another Carlin's curette which I am putting inside, and you can feel the grating sound. And can you see how the things are moving? In treatment of deformity, you have to create more instability. When you create good instability, then things are better, you know. So now that we have got this, sister, give me the microphone. Grating sound. And can you see how the things are moving?
Usually you require assistance for retraction, or there is some assembly for self?
There is assembly, but I have realized over a period of time there is nothing better than an assistant. The reason being that he knows exactly how much pressure, where to relax. And these self-retaining ones, once they are applied, you forget about them and you end up in a lot of muscle damage.
Assistance for retraction, or there is some assembly for self?
Yeah. There is assembly, but a lot of people ask me this question, why are you doing this way? So this, you can see now the entire joint has been prepared. Can you see? This is the middle end of the joint and this is the lateral end of the joint. So you have to take the midpoint of the joint
go 5 to 6 millimeters below and 2 millimeters medial. Is that what I'm saying? Yes. 2 millimeters medial and your screw should be directed pinch it 10 to 15 degrees laterally.
Okay.
Okay? So now I'm going to make a drill and pass a KR and just confirm that my direction is going to go correctly. So this is the drill. Is that what I'm saying?
Yes.
Oh, usko baba. ठीक है baba वो. Take something.
Okay. Okay.
So now I'm going to make a drill and pass a KR and just confirm that my direction is going to go correctly. So this is the drill. Oh, उसको बाबा ये बहुत बड़ा हुआ ओके ठीक है चलो so you have to get both are in the same plane. Can you see?
Yes.
Can you appreciate that the atlas and this axis, they should be in the same plane when you are going to pass your wires, your what is called K-wire or your screw. They must be in the same plane. Only then the area has been corrected. I would prefer if we could take a Siam quickly now, with this in position. Can you take a Siam?
Sir, sometimes the passage is entirely placed in hypertrophy.
Yeah.
In that case, how we make...
You can bring the, yesterday I showed that case of visual imagination with the facet overhang. You can bring that overhanging portion. You drill off the overhanging portion which is hanging onto the facet of the C2. Just like an osteophyte when you are doing subaxial spine, if it is encroaching on the anterior surface of the disc, you drill that. You drill that and you can see then you got adequate space to enter there. Remember the facet is very big. Drilling a few millimeters of the anterior aspect of the overhanging is not going to create any trouble for you. If it is encroaching on the anterior surface of the disc, chalo lateral karo. You do that and you can see then lateral karo, and when you doing the lateral, I will use the muscle to I'll hold the drill. Millimeters of the anterior aspect of the overhanging is not going to create any trouble for you. Chalo lateral karo. Can anybody hear me? Lateral karo, and when you're doing the lateral, I'll use the muscle to hold the drill. I'll hold the drill. Can anybody hear me?
Dr. Deshpande?
Yeah, can you hear me?
Yes.
So I'm seeing the neural structure here. You see the data here?
Yes.
So what I'm doing is I'm trying to see if I can decompress at till the spinal lamina junction.
So this is the traversing nerve root?
Yeah, that's right. So you see now you can see the decompression up to the near midline.
Right. So we'll just come back to you. We can go to OT3, Dr. Park.
Can you see the... Yeah, I'm removing tumor. Everybody coagulation, always coagulation. Shrinkage, yes, okay. Firstly, I have to find the tip of
Dr. Park, we see a lot of blood on the...
Coagulation. Sorry, I have to focus here, very important point. I can show you coagulation. You can see here, coagulation, soft.
Yes.
You can see the root right here.
Right.
And also you can see the mass, okay?
Yes.
So I am dissecting and removing. This, you can see here, root red and tumor, pituitary.
Okay.
Okay, we'll shift to OT2.
Yes,
Microscope view. OT2. आवाज नहीं आ रही है OT2 से.
You see the CM image?
Yes.
Can you see that the Atlanta axis dislocation is reduced completely?
Yes.
Now you see I'm placing the drill. चलो shoot.
Microscope view.
ये image है microscope view दे उनको. दे दिया microscope view?
Yes, now we can.
You can see I placed the drill as the plan what we did. अब आप CM करो.
CM is in PIP, yes sir.
Now you see I'm placing the drill. चारों मारे चश्मा कर दो दिशा तुम्हें.
Microscope view.
I can't see with my spectacles on. Microscope view दे उनको. दे दिया microscope view?
Yes, now we can.
You can see I placed the drill as ये right angle का हटा देंगे बोलूँगा तो. CM करो. हटा दो.
CM को PIP में
हटा दो. अभी शूट करो. चारों मारे चश्मा कर दो शूट करो. See, you can see my drill bit in the subfascial region. Shoot karo. Shoot karo. See, this is the direction because I am going to go towards the posterior, superior end of the lateral mass.
PIP को बड़ा कर दो.
अभी shoot करो. Can you see this? Can you see the drill bit?
No, it's not centered, so that's why.
No, I am asking to see the CM image.
Okay, CM we can see.
Can you see on the CM image?
Yes.
Very good.
posterior superior end of the lateral mass.
See, but you remember, when you remove the retractor, the dislocation is recurring a little bit.
No, it's not centered, so that's
See.
No, I'm asking to see the CM image.
You understand what I'm saying? Okay, so now you keep the retractor in position.
Very good.
अभी हटो. अभी shoot करो एक बार. Just hold it in that position.
See, but you remember,
But don't move now.
remove the retractor with the dislocation is recurring a little bit.
देखो, उसको position मिला.
You understand
He's pushing on the C1 है.
Now you keep the retractor in position.
हाँ, बस. अभी shoot करो.
अभी shoot करो एक बार.
Just hold it in that position. हाँ, कुछ गड़बड़ हो रहा है.
Shoot.
No, this is not acceptable.
Position मिला. He's pushing on the C1.
What is the issue, sir?
right there. अभी shoot करो.
अभी shoot करो.
Shoot करो. Extend करो. हाँ, कुछ तो गड़बड़ हो रहा है. हाँ, extension चाहिए. This is the position that we want.
No, not acceptable.
Now, will you hold it in this position?
Yes.
What is the issue, sir?
Okay, give me the drill system.
Right there. अभी shoot करो.
What?
Extend करो.
अभी फिलहाल मत कुछ बोलो, फिलहाल ऐसे रहने दो. I'll put the drill.
Extension चाहिए. This is the position that we want.
Okay?
Now, will you hold it in this position? Yes.
Okay, give me the drill system.
What?
अभी फिलहाल मत कुछ बोलो, फिलहाल ऐसे रहने दो. I'll put the drill. अभी shoot लो. See it in reduced position. Can you see? The posterior arch of the atlas and the spinal line of C2 are in the same line. Can you appreciate that or no? Okay. So I'm removing the drill.
अभी shoot लो.
System मेरा tap दो.
See it in reduced
मेरा
position.
tap.
Can you see? The posterior
Can you zoom in the CM image?
C2 are in the same line. Can you appreciate that or no?
Okay. So I'm removing the drill.
System मेरा tap दो.
मेरा tap.
Microscope view कर दो.
No, I want the drill. हाँ? हाँ. मैं drill bit के साथ में पूछ रहा हूँ.
CM image PIP में रखो.
Drill bit कहाँ है?
Sir, on the X-ray image, it seems to have
Seems to have
it become irreduced. I mean, less reduced.
के साथ में पूछ.
the one with the drill bit.
CM image PIP में रखो. Yes.
Can you extend it? That is, he removed the extension. Now just now see shoot करो. हरिया. Shoot करो.
Seems to have.
It become irreduced.
See now.
Yes, now it is.
Now you hold it in this position, my dear. Suction removal.
Yes.
Don't. Can you extend it? That is, you remove the extension. Now see, shoot karo. Hurry. Okay, now you hold this position. Will you do that? Okay. See now.
Yes, now it is.
Now you hold it in this position, my dear. Suction removal. Don't.
Please don't put pressure on the eyes.
Okay, now you hold this position. Will you do that? Okay, sister, tap to me. Okay. Where's my screw? क्या करना है यार प्लीज गिव मी द स्क्रू ये स्क्रू ड्राइवर में स्क्रू अरे यार वो इंस्ट्रूमेंट वाला नहीं है ना चलो तो डाल चलो वो
So when we do it posteriorly, sometimes to make it reduce, we just put a towel clip between C1 and C2 to keep it reduced.
Correct.
Can we do the same?
And we can put a tap.
Yes.
We can put a tap, and the tap can hold it in position. That is possible. I've shown in the video yesterday.
Right.
So this is the screwdriver which has got the screw fixed in it. Hold the holding extension now, darling. Holding an extension now. I want the tap. With the tap. That is possible. I've shown in the video yesterday. हमारा instrument में भी नहीं है ना tap. So this is the screwdriver which has got the screw fixed in it. Hold the holding extension now, darling. Holding an extension now. Correct. I want the tap. With the tap.
What is the length of the screw?
18 to 20 I put because yesterday I measured. So हमारा instrument में भी नहीं है ना tap. Yeah. एक बार shoot करो भैया. Shoot करो. See, you can see this. It is going in the lateral mass, in the center of the lateral mass it is going. Where it is going?
But do we pull it with the lateral?
Lateral and downwards. Shoot करो. See, you can see this. So this is going up. I need a bigger drill bit, which she doesn't have. She has only 3.5, she's saying. This is ज़्यादा drill bit नहीं निकल. है क्या? Lateral and downwards. नहीं है? She doesn't have, she's saying. So this is going up. I need a bigger drill bit, which she doesn't have. She has only 3.5, she's saying. This is ज़्यादा drill bit नहीं निकल. है क्या? This is my tab, you know. नहीं है? Sister, screw भर के जाना? Don't have, she's saying. Screw load करो, sister.
Shoot करके देख लें.
Shoot करो. Okay?
Yes.
The reduction is maintained. The screw is going to the lateral mass. Can you appreciate it?
Yes, yes.
And the spinal lamina line of the C2 and the posterior artery are in the same line.
Right.
Okay?
Yes.
This Dr. Research, they are asking whether he is happy or he does not agree. Okay?
Yes.
The reduction is maintained. Professor Researchy.
Yeah, congratulations.
What is your opinion? Are you happy with it?
I'm so excited to see this beautiful operation. My only question is, which is the length of the screw?
Yeah, yesterday I measured the correct screw for this patient is between 18 to 20 mm.
20.
Are you happy with it? There is screw driver, that's all. दूसरे किधर गया?
This beautiful
हाँ, इसको लगाया ना screw.
question is,
Okay, so this is the screw which is locked. The screw is locked in the. Yesterday I measured the correct screw for this patient is between 18 to 20 mm.
20.
क्या करी पागल है तू? There is screw driver, that's all. दूसरे किधर गया? हाँ, इसको लगाया ना screw.
Would a lag screw help? Although obviously length will never be available for lag screw.
Pardon?
Lag screw, so have you tried?
I don't like the lag screw. I like the. Is it going inside that? No, it is not going.
Would a lag screw help? Although obviously length will never be available for lag screw.
No.
Lag screw, so have you tried?
I can't feel it going inside that. Give me that tap of mine, sister. Give me my tap. See, I need a taper drill bit, which they don't have. They are saying. No, it is not going. I needed a drill bit which is fatter. not this. No. I need a fatter drill bit. I can feel it go inside that. Give me that tap of this somehow is not there. See, this is going beautifully into the lateral mass without any problem. Which we don't have. You're saying. Can you appreciate this? Yes, yes. Which is fatter. Not this. This has gone into the lateral mass. And the lateral, see, they both are fixed.
Yes.
The C1 and C2 are fixed. See, they are moving together into the lateral mass without any problem. See. See. Can you appreciate this?
Yes, yes.
Can you see this?
Yes.
This has gone into the lateral mass. And the lateral, see, they are fixed.
Yes.
Scoliosis system. The C1 and C2 you know screw, see, they are moving together. क्या हुआ? फिक्स किया ना? ठीक है. Can you see this?
Yes.
Scoliosis system. Show me the lateral mass.
शूट करके देखो.
क्या हुआ? फिक्स किया ना? ठीक है. Siam. Shoot.
Can you show at the microscope the
Yes. Can you see the screw has gone across into the lateral mass?
lateral profile
Yes.
of the lateral mass joint?
Yeah. I'll show you. Under the microscope?
Yes.
Show me the section. Okay.
Can you show at the microscope?
See this. This is the lateral profile.
Beautiful. So you are in the middle but closer to the midline. Right?
Correct. And I passed it laterally. I passed the screw laterally. But can you see this now? They are moving in one. There is no separate movement between the atlas and the axis.
Yes.
And can you see the C-arm image?
Yes.
That the screw has gone into the atlas, or across the atlas. Can you see?
Yes, sir, we can see.
Okay, give me the screwdriver, please. And I passed it laterally. Please give screwdriver the color. But can you see this now? They are moving in one. There is no separate movement between the atlas and the axis.
Yes.
And can you see the C-arm image?
Yes.
So I'll still put the bone grafts inside, you know? Across the atlas. Can you see?
Yes, sir, we can see.
Okay, give me the screwdriver, please. Just give screwdriver. So now remove this. Now on the C-arm, you do flexion. Catch the lateral this. Yes. And fluoro chalu karo. Very flex. There is no movement on flexion extension. Can you see that?
Yes, yes, we can.
Extend karo. Flex karo. Can you appreciate that there is no movement between the atlantoaxial joint? Can you appreciate it? Very good. Put it down. Okay. So now I'll put the screw on this side, then I'll put bone graft in the joint, and then we'll cover it.
Yes, yes, we can.
Afterwards. Because there's little deformity correction here, but we can always pack it, there's no problem. There is no movement between the atlantoaxial joint. Can you appreciate it? Very good. Put it down. Okay. Yeah, but we have to put cortical cancellous chips. I don't want to put any distraction.
Thank you, Dr. Patkar.
Yes, sir. Did you appreciate the fluoroscopic view that there is no movement?
See it very nicely.
Very good. What about Professor Visocci? Did you see that? Because he is a man with a lot of experience in this case. Professor?
Yeah?
What is your opinion? Is it correct?
Very good. Very good.
Thank you. Thank you. Right angle, please.
Thank you, Dr. Patkar.
Thank you. Right angle.
Thank you.
We shift to 83.
See it very nicely. Very good. What about Professor
Dr.
Visocci?
Park?
Did you see that? Because he is a man with a lot of experience in this case. Professor?
Yeah?
What is your opinion? Is it correct?
Very good. Very good.
Thank you. Thank you. Right angle, please.
Thank you, Dr. Patkar.
Thank you. Right angle.
Thank you.
We shift to 83. Dr. Park?
For me?
Dr. Park?
Yes. Correlation. Yes. Correlation. I can hear you. Correlation.
Yes, how much tumor you have removed?
Shorter cutting. Just before I remove the tumor. So, yeah, you can see the root here.
Yes.
And here is the duotomy, okay?
Yes.
And this is the root, which made the tumor, root cyst, which made tumor. So, I am really tumor is removed. So, I don't know. I will explain the surgical anatomy.
Right.
Yeah, I made a pterygotomy here.
Yes.
And this is a root red.
Yes.
You can see here. Here is this is a tura, and root red is here. You can see root red.
Yes.
After moving the IDM into the extradural area, and I removed it. So this you can this is root, which made schwannoma here. So this will remain the pituitary, partially remain the less pituitary. So this one, this you can see here. So I wanna cut here. Remove here. Okay, move the lateral side. Okay, and then with RF I will cut here. Okay, holding it like this. RF, please. Okay, holding again, okay, like this. It's good. Quarters, please. Cutting, please. Cutting. Shortly. Cutting. Cut. Correction. Okay, it's good. No. Line. Please keep the line. Okay, we are here. So, double end. Steady free. You can see pterygotomy here, double end. Wait a minute. Pterygotomy here. Wait a minute. I have to find the. Where is the plastic? I'm looking for the plastic. Okay. 줘봐요. And pressure increased height. Pressure increased what height? Press height. What level increase? Okay.
44 you are connected, sir. Yes, okay. Yes, Dr. Deshpande. Hello. आवाज नहीं आ रही OT4 से.
Can you hear my voice?
Yes, now I can.
So this is the L4 lamina.
Right.
This is the area of the Campbell's triangle.
Right.
This is the S1 pedicle just below this.
Yes.
So what we are seeing is, I took a little bit of time because I'm a little concerned about, give me a dissector please. Quiet, don't talk. Quiet please. Here in the OT. Can you see the dura here?
Yes.
And there seems to be a sort of a structure which appeared to us like possibly like a horizontal nerve root. See, it's coming from here, but I'm not sure. So I'm not going to touch this. I don't have stimulation, so I'll leave it like that.
Right.
Could be, I don't know what this is. There seems to be initial area where I can find the space, but I'm not sure. I don't want to cut this off. Interesting thing in all this is, the discussion was it is fused, right?
Right.
So I'm going to the disc space here, correct?
Yes.
Okay? And I'm seeing whether the L4 is moving or not. Okay?
Yes.
Sorry, the L5.
L5 over S1.
See the L5?
Yes.
Can you see the L5 moving?
Yes.
Huh?
Yes, we can see.
So that's my concern, because many times we think that it is fused, but it may not have been fused very nicely, except the anterior. Can you see the movement now?
Yes. Dr. Patkar has left.
No, I'm here. They're removing harvesting bone graft.
Okay. Right. Thank you so much.
So did you appreciate the points, technical points?
Yes, sir.
Now, once the joint is fixed on one side,
OT2,
Yes.
Patkar has left.
no, I'm here.
Audio has
They're
gone.
removing harvesting
OT2.
bone graft.
Okay.
Now, on the other side, you just have to get the screw across the joint.
Correct.
Yes, sir.
With bone grafts inside the joint. So, if you can see here, show me that implant because I assisted. मेरा implant दिखो.
Yes.
Camera को इधर ले जाओ.
Audio has gone. OT2.
So there is an array of plates, and if you can see, these are special cages which are made. इसको focus करो. So if you can see, give me a forceps system. मेरा implant दिखो. Can you see these wedge-shaped cages?
Yes.
So these are been made for Jeon for me in various sizes, and they go right up to 12 mm.
Okay.
But the average ones which I put are between 5 to 7. And see this, they are of different shape, unlike what Atul Goyal or Dr. Sarat Chandra used yesterday. And these sit in the center of the joint. First I pack the joint with bone graft behind and then push this cage. The purpose of the cage is only to maintain the distraction, and there is enough space for bone inside, and then I put this plate across. You can see this VSP plate?
Yes.
So one screw goes into the lateral mass and one screw goes into the body of C2. And this plate will sit flush with the facet joint. Sometimes I have to fashion, with a bore, I will fashion the surface, there will be a flat surface, and the plate fixes into the body of C2 and into the lateral mass of C1. So this is the option if you are not able to pass these transarticular screws. And the plate design is a VSP design. So you pass the first screw above, and then the second screw you pass very close to the edge. The screw goes inside, the width of the screw, it will slide upwards and cause compression of the C1, C2 joint.
Okay.
You get the point I'm making? Yes. This is a VSP principle. The first time when I sent it to the journal Neurological Research that I'm edited, Denzel had a nice talk with me saying this concept seems to be very nice for treatment of fractures using a VSP plate.
Okay.
This is another plate which has been devised for this area, C1, C2 area. And you can see this, there are places to pass the screws. One screw in the center for the distal fragment of the odontoid, and then two in the body of the C2 and one in the lateral mass each.
Oh, very nice.
So this is also made by Jeon for me. Of course, I have absolutely no financial interest in the manufacturing or in his profits. It's just that he should prepare everything, get it ready for me whenever I want to operate. And then two in the body of the C2.
Thank you, Dr. Bhatt.
Thank you.
We shift to OT3.
Very nice.
So this is also made by Jeon for me. Of course, I have absolutely no financial interest in the manufacturing or in his profits. It's just that he should prepare everything, get it ready for me whenever I want to operate.
Right, Doctor. Thank you, Dr. Bhatt.
Thank you.
We shift to OT3.
Correction. Stop. Be careful. Correction. Maybe breathing focus is here. You need a pack. Maybe here. So gel foam and maybe some I don't know, some arterial bleedings here. So correction. Whether you're here. maybe here is the main breathing focus. Cutting. We can put diaphragm again. Put diaphragm coagulation. Do you have a surgery cell coagulation? This is surgery cell. We can pack it here. Arbitel or other things.
So Dr. Park, we are with you. Now you're going to close the dura.
Yeah. After bleeding control, we remove the tumor, and next time is closing dura, but there are some arterial bleedings, so I'm controlling the bleedings.
Okay.
After bleeding control, we can close the dura, double N. Maybe here. I hope here is the bleeding focus. I think this is a very good idea. And cotonoid, please. You have other things. This one. Hope we can control here. This one. Okay, and here. Maybe. Double M, please. Double M. Pituitary, please. This is gel form. surgery cell 뭐야? 본인이 잡는 게 뭐라고 하지? Okay, be careful, be careful. You don't care. This is root. Yeah, over the root. Okay, this is urotomy, okay? Double M, please. Pituitary, please. Pituitary. This is your gel form. Surgery cell. Glazing your surgery cell. Here we for surgery cell. Surgery cell is best. Here is no bleeding, okay? But bleeding may be here. It's 6 or 5 o'clock. So I want to try here, okay? And hold it like this. Hold it. Double in, double in. Okay. I hope you can control the bleeding here. Here. Okay. This is okay. And
tell me when you are hearing. Yeah, so we are now ready for the other side. We are getting ready to pass the screw on the other side. And like I said, once you have got one screw good, then the other side is pretty simple.
And
tell me when
we are hearing.
Yeah, so we are now ready for the other side. We are getting ready to...
In posterior person, we put the bone graft first and then...
Yeah, we are going to put the bone. See, today I was reading, see, it is very, when you do demonstration surgery and all, you are actually Hawaii style, you know. So now I am going to put the bone grafts in this joint first.
So we will unscrew some threads before putting the bone graft.
Pardon?
We can loosen the screw to put the bone graft or...
No, we are putting only, we don't want any distraction. We are putting cortical cancellous strips. So now I am going to put the bone grafts in this joint first.
So we will unscrew some
थोड़ा भी curate ले लो, curate दो, joint को साफ करो.
We can loosen the screw to put the bone graft or...
No, we are putting only, we don't want any distraction. Curate दो sister. ये नहीं. हाँ ये दो.
चलो so we are curating the joint. चलो अभी curate ले लो. Curate दो, joint को साफ करो. Curate दो sister. Even the drill, you got a drill with a burr, very fine burr. उसको एक fine burr लगाओ. चलो so we are curating the joint. Put a fine burr on the drill sister. Even the drill, you got a drill with a burr, very fine burr. देखो एक fine burr लगाओ. इससे बड़ा लगाओ देखो. इससे बड़ा burr लगाओ. Put a fine burr on the drill sister. देखा मेरे को. आइए चलेगा. लगा दो इसको. देखा. इससे बड़ा लगाओ देखो. इससे बड़ा burr लगाओ. मेरा इसमें मिस्टेक क्यों हो रहा है यार? ओरिएंटेशन है मेरा. I positioned it correctly, but while going I am making an error. तो ठीक होगा. नरेंद्र, you proceed. चलो लाओ इधर सिस्टर बर ला आगे ला. मेरा इसमें लगाएगा बर. दिखा दो. ओरिएंटेशन है मेरा. I positioned it correctly, but while going I am making an error. तो ठीक होगा. नरेंद्र, you proceed. चलो लाओ इधर सिस्टर बर ला आगे ला. ना एंगल हैंड पीस पे लगा. दिखा दो. Angle and piece below. You can put this in the joint and घुमा it. See whether this is going in the joint. दिखा. Is it going? Now घुमा it. Just keep on. Don't push it too much inside. Keep on घुमाएंगे it. Angle and piece below. Are you not waiting? You can put this in the joint and घुमा it. ज़्यादा मत डालो अंदर ना. See whether this is going in the joint. Very good. निकाल दो. Is it going? So now see the cartilage is injured and there is bleeding. So it is अभी बढ़ गया sister. अरे ना very good. ज़्यादा मत डालो अंदर ना. Very good. निकाल दो. So now see the cartilage is injured and there is bleeding. So it is अभी बढ़ गया sister. थोड़ा सा टिल्ट में फिक्स हो गया ऐसा लग रहा है मेरे को. इधर स्पेस कम है. वो साइड में स्पेस ज्यादा है. जानते पर फिक्स दैट इज मोर देन सफिशिएंट. ला इधर. ये देखो इसकी जाता है देखो जॉइंट में अंदर डाल दो इसको. फुट स्विच पे पहले फुट रखो. डोंट प्रेस इट. फुट स्विच की तरफ देख लो. वो साइड में स्पेस ज्यादा है. एक बार लगा के देखो चल रहा है ना. बस बस चलो अंदर जॉइंट में डाल दो. ये देखो इसकी जाता है देखो जॉइंट में अंदर डाल दो इसको. जॉइंट में जाने दो पहले अंदर. फुट स्विच पे पहले फुट रखो. डोंट प्रेस इट. वो अंदर उसकी तरफ देख लो. चालू करो धीरे धीरे. एक बार साइड टू साइड चल रहा है ना. बस बस चलो अंदर जॉइंट में डाल दो. बस जॉइंट में जाने दो पहले अंदर. बस 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 बहुत हो गया. बहुत हो गया बहुत हो गया. चलो बोन पीसेस भर दो अंदर. साइड टू साइड. बस 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 बहुत हो गया. बहुत हो गया बहुत हो गया. चलो बोन पीसेस भर दो अंदर. बहुत बड़ा है. जाओ ना डाल दो फिर. ये इंस्ट्रूमेंट लो. या बहुत बड़ा है. जाओ ना डाल दो. ये इंस्ट्रूमेंट लो. या इससे लंबा स्क्रू है क्या? इससे लंबा स्क्रू है क्या?
Hello, 41 you are connected, sir.
बोन ले लेना.
Hello, 41 you are connected, sir.
बोन ले लेना.
क्या?
बोन पकड़ लेना. Connected to the audio in auditorium.
I think definite mobilization. I can just show Nelson Peterson Panther or Stotolo if you want. Can you give me Christian, please? Thinking, cleaning here, 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 here. Sometimes I say here, 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 here. Yes. Indeed. Do you have bearing? How do you?
बोन के साथ देना चाहिए. एक लूप बना के देना. ड्रिल और बोन के.
Drill.
ड्रिल नॉर्मल.
High speed. Just show.
Okay, sir. 42 you are connected, sir.
See now. Go ahead. Drill with me.
ऑन करना चाहिए.
So you will again sir see in the CM or it's just okay to go ahead with the.
उसका डायरेक्शन ऊपर होना मांगता है, ऐसा नहीं, ऐसा होना मांगता है. समझ गए ना?
42 you are connected, sir.
See now. ज़्यादा लेटर नहीं.
Hello, Dr. Patak, sir.
इधर देखते रहो. हाँ, ठीक है, जान दो. तो ड्रिल मारो. एक मिनट मेरे को इंस्ट्रूमेंट को तो नंबर 4 उसका डायरेक्शन ऊपर होना मांगता है, ऐसा नहीं, ऐसा होना मांगता है. Yes.
So sir, we need to see again in the CM or it's just.
We will pass the drill for a few millimeters and check in the CM. So drill मारो. एक मिनट मेरे को इंस्ट्रूमेंट को तो नंबर 4. अच्छा तो बोल, tell me what you want I'll do. Yes. चलो ठीक है. अब हो गया. Suction दो मेरे को sister. We will pass the drill for a few millimeters and check in the CM. See this. हाँ. Okay. One minute. बोल, tell me what you want I'll do. चलो ठीक है. अब हो गया. Suction दो मेरे को sister. Yeah. थोड़ा सा. So look at, keep on looking at the lateral. Which vessel? 1 minute. So I'll get it out for you. Yeah. No, it has to. Keep on looking. Yes. Keep on looking at the lateral. थोड़ा और डाउनवर्ड टिल्ट करो, चलो करो करो, फाइन करो. So I'll get it out for you. एक मिनट रुको. हाँ चलो अभी देखो. Keep on looking. हाँ. Yes. करो. Yeah. Whatever. I can see your tip. टिल्ट करो, चलो करो. करो फाइन करो. थोड़ा डाउनवर्ड टिल्ट करो. And laterally. Medial to lateral जाओ. हाँ. करो. Whatever. I can see your tip. थोड़ा डाउनवर्ड टिल्ट करो. ये होल तो बराबर ले आपने, लेकिन and laterally. No, it is medial to lateral जाओ. हाँ. No. निकालो. Okay, very good. देखो अभी. ये होल तो बराबर ले आपने, लेकिन देखो अभी. मंगा दो, टिश्यू हटा दो ना कॉटरी से. नहीं एक वेसल के ऊपर. ओके चलो ठीक है. ओके वेरी गुड. चलो देखो अभी. देखो अभी. मंगा दो, टिश्यू हटा दो ना कॉटरी से. नहीं एक वेसल के ऊपर. लेट अस सी. या जान दो. चलो.
41 you are connected, sir.
Yes. So let us see. Yeah, जान दो.
41 you are connected, sir.
Before. What's blood pressure?
Blood pressure?
Yeah.
72 means.
71,
72 means.
Okay.
Only one muscle.
Okay. Maybe make injection dexamethasone. Maybe 34 milligrams.
How much milligrams?
34 dexamethasone. 34. Maybe 20, 25. Can you do?
That's what they're saying. It should improve.
Should improve.
It should improve. We'll do it after some time.
Can you do me for filling spinal cord dissector. Okay, do we have red please? Just red, give, no, red. We do, I think.
3-rod technique.
Yeah. Okay. Can you cut? Open. Yeah.
cut. Yeah, good. French bender. Can we water here? Cup. Maybe you repeat stimulation. Good? Okay.
So this way a desired correction?
Yeah. I'm thinking, okay. Maybe let's cut more. Open. If you want, I can. Okay.
To the maximum.
Good. Yeah. Okay. Set screw. Rocker. No. Do you have rocker? No. Rocker. It's possible to use. Possible. But we should have a little another. Yeah. Yeah, hold this. No. It's good. Yeah. Yeah. Rod holder. Rod holder. Yeah. Another one. Two. Try to make the rotation. No, UBB. Это direct the rotation. I don't like it.
So this technique is called.
Yeah, hold this. Hold this. Mm-hmm. Hold this. Hold. 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 Last one. Yeah. Take this and yeah. Can you push? No push. Just right.
Okay.
Yeah. Good. Yeah. Okay. Sec, please. Okay, next stimulation. Good. Screwdriver. Yeah. And distractor. Hold. Yeah. Fix. Yeah, fix.
Good. Yeah, fix. Yeah. Hold. Yeah, fix. Next. No. Hold. Fix. Yeah. Yeah, fix. And yeah, fix. Good. Okay. Rod. Yeah. Cut. Good. And we need in situ bender. Yeah. 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 Maybe we start here. Maybe cut a little more. A little. Yeah. Yeah. Give me set screw. No. It's here. Cup. Yeah. Screwdriver. Give me please.
Screwdriver then ID nahi.
No.
Hello. OT4, you are connected, sir.
Can you hear?
Yes, sir.
So I want to show you how much gap there is in the so-called disk space. Can you see now? Can you guys see? Hello? Can you hear? Can you hear? Is the screen visible? So this is the L5S1 disk space, and actually in the front,
Yeah, we can see Dr. Rajkumar.
you can see the anterolongitudinal ligament at the here. Can you see?
Yeah.
So even in this case, and give me a straight dissect, straight curate. The doubt was whether there is movement, right? Whether it is fused, right? So I'll show you this. Can you hear?
Yeah, we can see.
Can you see the movement?
Yes, we can appreciate.
So it is not really fused. So I just put a trial cage, 8 millimeter, I can do it. You can show on the screen that we have put a trial cage. And then now what I'll do is I'll leave at this and go for the L45 because that's another fusion plan. We'll do a similar discectomy, facetectomy for L45 and then we'll do a pedicle screw fixation. That's the plan.
Sir, in case this was fused, what would be your approach? Would you have gone in and chiseled it out anteriorly?
That was not chiseled. I would have sort of broken it. I would try simpler thing. I won't do some crazy stuff, put a chisel there and all that. But I can do it in my setup because I know how much I can go. In a demonstration case, I don't want to do that. Second thing is, somewhat I was sure that this would move. And therefore it has moved. In a completely ossified, not just calcified. Ossified, well, you don't have to do anything, just do decompression.
Thank you, sir.
So I'll go to the next level now, okay? Thank you guys. I can do that if you want. You have the cage ready, 8 and the bone. You can do that. Cage here. Do you guys have cage? 8. Oh, you wanted to see Sachin? Come. You can see now. Can you see the movement? I don't know about that. Let us try. I'll put the cage and we can start pulling it up. So do you want me to do L45 or you don't want me to do L45? What? $8.22. And give me the bone. Where's the bone? Let me start putting bone. Hold. If you don't want me to put, I will avoid. I can go straight away for a no, trial done. There. We put, sir. Sachin is doubting what is this man doing, coming here and putting simply some muck inside. No, bhai. What happened?
Sir, I had another question. When would you think of extending it to S2 LR?
You're asking me?
Yes, sir.
See, in patients who are osteoporotic, adding another level is a insurance. The instead of S2, I would sometimes prefer to go to AIIMS. AIIMS screw, you can put a very long screw. S2 can be very weak. So S2 is something I'm not very comfortable. I would rather put a long, thick AIIMS screw ELAM has an advantage that it provides significant strength. Also in patients who are elderly, the SI joint will be getting arthrosed. So if there is any pain in that area, for whatever reason, the screw also aids in giving support. So iliac extension is when you think that the S1 substrate is not sufficiently strong. You need some? Does that answer your question?
Yes, sir. Thank you.
Iliac screw by MS can be tricky if you are not in the correct alignment. It can be done, but I would rather put that under open. Because aligning the heads under any condition will be tricky. I notice I am putting it more anterior. I am putting the bone anterior, right? Then the cage will go behind it. Let's see if I can get a reduction. I don't know how strong is the bone. Enough, that's enough. Have the cage. Hold this. Making it more loose, huh? Give. Should be okay. That's it, that's it. That man, it doesn't go. What? This is useless.
Please connect to OT2.
But the odontoid has been now brought back into the center.
OT2 you are connected, sir.
Patkar sir, you were showing some things?
Yeah, we are much better. You can see the lateral mass में screw बराबर जा रहा है, दिख रहा है ना? On both sides, the screw is going in the lateral mass and the odontoid is in the center. But the odontoid has been now brought back into the center. Now you can see. इसको हटाओ. ये image दिखा सकते हो क्या उसके ऊपर? Can you show this image? Dr. Agarwal, can you see this AP image?
Yes, sir, we can see it.
Can you see the screw go across the joint up to the upper outer border?
Yes,
on
sir.
this side and this side.
Yes, sir. One right side is clear, left side the image is not clear.
दिखा सकते हो क्या उसके ऊपर? Can you show this image? Dr. Agarwal, can you see this AP image?
Yes, sir, we can see it.
Can you see the screw go across the joint up to the upper outer? Now we'll show you the dynamic fluoroscopic view. इसका lateral करो.
One right side is clear, left side
अंदर करो.
the image is not clear, sir.
See, this is the lateral mass.
So in C1 lateral mass, it has to cross the bicortical purchase sort of?
No, there no need a bicortical purchase. They should have good adequate purchase. अभी जाओ पीछे जाओ अंदर करो. अभी हाइपर एक्सटेंशन में जरा इसको कम करते हैं हाइपर एक्सटेंशन को. अभी शूट करो.
C1 lateral mass, it has to
cross the bicortical purchase sort of?
No, there no need bicortical purchase. They should have good idea. चलो आ जाओ पोजीशन में. अभी जाओ पीछे जाओ. पोजीशन में आ जाओ कि नहीं? अभी शूट करो. एक्सटेंशन में जरा इसको कम करता है हाइपर एक्सटेंशन को. अभी शूट करो. एक मिनट मेरे को पोजीशन करने दो. एक मिनट. उधर जाओ. शूट. हाँ चलो आ जाओ पोजीशन में. बराबर नहीं आ रहा पोजीशन. पोजीशन में आ जाओ कि नहीं? उसको निकालो वो आर्टरी फोर्सेप्स को. You do it. आपने किया. हाँ you do it better than me. I have to see the screen also. हट जाओ सिस्टम. एक मिनट. शूट. ये बराबर नहीं आ रहा पोजीशन. ओके. उसको निकालो. करो स्टार्ट शूटिंग. Can you appreciate that there is no movement between the atlas and the axis? I have to see the screen also. Hello.
Yes, sir.
It is
Is it possible to restrict the movement of subaxial spine to actually see the flexion extension at C1, C2, sir?
Normally when we do flexion extension also we are doing the same thing.
Hello? Yes, sir. Is it possible to restrict the movement
Correct.
of subaxial spine?
तो ये निकाल के करना पड़ेगा. ड्रेप को थोड़ा ये टावर क्लिप निकाल के पूरा फ्लेक्स करो.
Extension at C1, C2, sir.
हाँ. उठा सकते हो सिर को. हाँ उठा. उठा. तो शूट करो. शूट तो करो. करेक्ट. तो ये निकाल के करना पड़ेगा. ड्रेप को थोड़ा. See now we have brought the chin almost low down. अभी भी थोड़ा एक्सटेंशन ही है. हाँ उठा. उठा ऊपर उठा. उठा. तो शूट करो. हाँ. ओके अभी शूट करो. शूट तो करो. See,
yes,
the spinal laminar lines remain the same line with the posterior arch of the atlas. Almost low down.
Yes,
Can you appreciate it?
Yes, sir.
Okay, extension करो. Rotation करो. Okay, अभी shoot करो. Shoot करो. ये बाजू में rotate करो. दोनों बाजू में करो. Spinal laminar lines remain the same line with the वो बाजू में करो. posterior arch of the atlas. Shoot. Can you appreciate? करो बाजू में. Shoot.
Yes, sir.
करो और करो. Okay, extension. हाँ ये straight position है. Rotation करो. So now you see the posterior arch of the atlas bang in line with the spinal laminar line.
Yes, sir.
Can you appreciate it? This is the straight position. You can see these screws and you can see the posterior arch of the atlas with the spinal laminar line. Shoot. करो और करो.
Yes, sir.
हाँ ये straight position है. Okay. So operation is over. Thank you very much. Any questions? Spinal laminar line.
Yes, sir.
Can you appreciate it? This is the straight position. Hello.
Yes, sir. We are very thankful to you, sir. We had a very nice understanding of the surgery today, sir. Yes, sir.
Okay.
Sir, I had one question.
Two questions. Not one, only two.
Post-operatively, how much of the rotation is hampered?
Totally hampered. Totally hampered.
Thank you.
That is the only movement in the atlantoaxial joint. The moment you fix the atlantoaxial joint, the rotation is gone. A good fixation means the rotation of the atlantoaxial joint should go. Now the rotation will be in the subaxial spine.
Post-operatively, how much?
The atlantoaxial joint is only one movement, that is rotation. Totally hampered. You understand what I'm saying? The only movement in the atlantoaxial joint, the moment you fix the atlantoaxial joint, the rotation is gone. A good fixation.
Yes, sir, we understand, sir.
Yes, so if the rotation is not gone, that means the operation is incomplete.
So
the atlantoaxial joint is like saying, I did abdominal terminal resection and the patient had children after that. That is not possible. Hello? Hello?
Yes, sir, we understand, sir. We understand.
Yes. After abdominal terminal resection, the person had children. That is not possible.
So, Doctor, I am back here, Dr. Patkar, Dr. Sushil here. So, any final comments?
Final comments, nothing. You should have an array of implant, you should have an array of instruments, and the technique is very simple. How much is the blood loss, doctor? How much is the blood loss?
So, Doctor, I am back.
Less than 50 ml blood loss. So,
yes, excellent.
There is no vertebral artery, no venous plexus bleeding, and your Vasilievich cautery is fantastic. You know, Vasilievich was the father of modern anatomy, and his cautery, I think, you know, is much more, will become more popular than his textbook of anatomy.
Correct.
So,
So thank you so much, sir. I think the audience, I have got the feedback. People really enjoyed. They were asking why this technique has not been popularized.
The only reason is that the posterior C1, C2 fixation was described by people like Nagel and Figer and all these guys were orthopedic surgeons.
Right.
Microsurgery came in by the neurosurgeons and the neurosurgeons stopped short at the C3-4 disc.
Why this technique has not been popularized.
And they turned behind and did it from behind by tradition. I think it was by tradition. It's just like, when I started neurosurgery, there was nothing like Smith-Robinson period. There was only staggered laminectomy and we used to open the dura and cut the denticulate ligaments.
Right.
And then I have even published a paper in Neurology India at that time of seizures with pneumocephalus after cervical spine surgery. Can you believe that? Can you get cervical after cervical spine surgery now, seizures? You cannot because we do it from the front.
Yes.
But it took few years for things to change from laminectomy, opening dura, cutting denticulate ligament to anterior fusion. Same thing will happen to this operation. You see the recent literature. It is my friend Professor Vasilievich who will make this popular. And here he is writing about this. Recently also he wrote about craniovertebral surgery, the evolution. I read that paper of his about the evolution of craniovertebral surgery. And in that paper also he has mentioned how the transition is taking place from posterior to anterior. Am I right, Professor Vasilievich? And here he is writing about this. Is he there?
Yeah.
He had recently written about the history and evolution of craniovertebral surgery and how it has evolved from posterior to anterior.
Good question. You know that there are in the United States and UK they say many ways to skin
a cat. Yes.
That means that you can get the center of a ball by a different way. The problem is that the head and the cervical spine is not a ball and is an asymmetrical issue. So I think that the great advantage of posterior goal fixation is the invention of something new at that time, but with the risk of blood loss, significant blood loss, the risk to damage C2 root, and the risk to deal with vertebral artery close to the surgical target. I had a case of vertebral dissection without hemorrhage, but with ischemia, fortunately compensated by contralateral feeding. The advantage of anterior approach that you so successfully shown us is that the surgical the surgical domain is cleaner compared to the posterior one, less blood loss, wonderful control of C1, C2 joint. Vertebral artery is quite far lateral compared to the posterior one. On the other hand, we have two drawbacks, two risk, theoretically two risk. Number one is the nerve apraxia of hypoglossal nerve that we have to shift per at least one half hour with the spreader. So this is a significant risk. We have also the risk that we can produce a stupor of the superior laryngeal nerve with postoperative dysphonia. Sometimes you can restore it, sometimes you cannot. I think that your approach is just the modified McAfee approach, like the one that I yesterday described and today I have to underline again. So our approach is quite the same. The unique the difference is the skin incision. That is longer in your case, a little bit shorter in my experience. But to make a longer skin incision allow the possibility to shift deeper tissue during the operation and to gain more access to the craniovertebral junction. So again, many ways to skin a cat, different strategies to choose posterior instead of anterior and vice versa, some trick and picks in each one of us experience. I think that the final result is brilliant, and you fired in me many ideas in this moment to add something more. I will explain as I concretize my idea when I return back home, and so please keep in touch for the future. Many ideas in this moment.
Too much.
Thank you, Dr. Patkar.
Thank you.
Add something more.
So we shift to OT3, Dr. Park.
As I concretize
He's putting in the
my idea when I return back home, and so please keep in touch for the future.